I have got the chance to express my view at this platform in this international conference. So coming to my topic, which is related to the patient's physiotherapist attitude or physiotherapy students attitude treating patients with psychiatric illness. So introduction, mental disorders or psychiatric illness comprises a broad range of problems with different symptoms. However, they are generally characterized by some combination of abnormal thoughts, emotions, sorry, abnormal thoughts, emotions, behavior, and relationship with others. Mental health is the foundation of well being and effective functioning of individuals. People with mental illness are often wrongly accused by being violent, unpredictable, helpless, incompetent, and untrustworthy, and they are confronted with misrecognition, prejudice, confusion, and fear. These negative responses to people having a mental illness are seen as a major obstacle to recovery by limiting their opportunities and undetermine their self-esteem. And this is the main reason why even many times physiotherapists don't openly approach to a psychiatric patients or patients with mental illness and treat them in a very positive way. Stigma. Stigma and unfavorable attitude towards psychiatric patients and mental illness or psychiatry still exists among this general population, and the medical professional, excuse me, some pop-up messages coming continuously.
From where you are receiving, madam?
General population and mental professional professions at large. Mental health and psychiatric illness is not the area. How to move this window? Actually, in my presentation, one pop-up message is coming continuously.
It's a default in your system, madam.
Okay, okay. So I cannot see my PPT also properly. That's fine, no problem. Mental health is the foundation for well-being and effective functioning of individuals. People with mental illness are often wrongly accused or of being violent, unpredictable, helpless, incompetent, and untrustworthy, and they are confronted to with misrecognition, prejudice, confusion, and fear. So, role of physiotherapist in mental illness is to facilitate motivation by providing encouragement, emphasizing strength, offering positive feedback, addressing values, and mobilizing guilt into goal acquisition. Empowering patients who are having psychiatric illness by providing activities that offer opportunities for self control and success have shown to decrease mental illness like depression, and that's why role of physiotherapist is really a vital in treating psychiatric patients. Physiotherapist or therapies offered by physiotherapist include and are not only limited to cognitive therapy or guided imagery or awareness, relaxation, yoga therapy, or sometimes even the ayurvedic treatment like chitta virod is all coming. So there are many treatment approaches available from physiotherapist point of view in treating these patients, like even guided imagery, sensory motor movements, relaxation, breathing techniques, yoga therapy, and physical exercises, even aerobic exercises or registered exercises. They are found to be very effective in treating psychiatric patients, and there are many studies which says that if you give aerobic exercises for 3 months to a psychiatric patient or to a depressed patient, definitely their depression is improving, their anxiety is reducing, cognition is improving, and many positive effects are seen. But the question here arises that how to motivate such psychiatric patient get to get motivated themselves so that they can be a part of your treatment protocols, or they can do the treatment protocols. They are practicing these treatment protocols with very effective manner. So it is a really a challenge for all the physiotherapists. First, very important thing is find out why they are suffering from such mental illness. What is the basic reason behind it? Which for that the psychiatrist, counselor are there to help physiotherapists. But finally, again, when it comes to exercises, motivation is very very important. So that part we have to deal with, and to motivate patients, we physiotherapists must get motivated to treat such patients. We should have that empathy, that what problem they are suffering, and accordingly we can treat them properly. So aim of this study, what study I have done to find out the attitude and approach of the physiotherapy students. So what aim of my study was to find out this approach, and uh, find out the students approach and attitude, and how they are going to behave, what is their knowledge treating such patients, what is their attitude component, and how this attitude and knowledge correlates between this is very important. And that is what is the aim of this study in my this research. So coming to methodology, in this observational study which was conducted at Dr. D.Y. Patil College of Physiotherapy, Pune, we after the ethical approval, this study was conducted, and we have chosen certain questionnaires which we circulated to physiotherapy students, 305 physiotherapy students from Pune, and out of that we received feedback from 191 students. So the response rate was 62.62%. And this knowledge and attitude towards patients with psychiatric illness and mental health, along with their learning experience and need to specific knowledge before stating psychiatric ward posting was assessed. For the assessment of attitude, we have used Mental Illness Clinicians Attitude version 4, that is MICA version 4 scale, which was developed by King's College London. Permission was taken from this college to use this scale by the students. It is a self-administered scale, usually requires about 5 minutes to complete it. It is constructed using 6-point Likert scale. So a student has to mark on that scale according to the Likert scale. And then for knowledge component, self-made questionnaire was constructed using 5-point Likert scale, having 10 questions, and was validated by 15 professionals before giving it to a students. Then a person's MICA score is the sum of the score for the individual items. Like there are certain questions where they're strongly agreed, it was given marks like 1, agreed to, then neutral, then strongly disagree was given as a 6. Like that in the scale it was given. And there are certain questions like 1, 2, 4, 5, 6, 7. Like there are certain questions in the scale which scores reverse way. Like strongly agrees, then gives 6 points. Agree is 5 points, like that. And minimum, the if we count this total score, the minimum score comes to 16 and maximum comes to 32. So when we interpret this scale, if the score is coming from 16 to 32, that indicates very positive attitude with no room for improvement for this treatment of the psychiatric patient. Then 33 to 48, if the score comes, then that is moderately positive attitude. So that indicates that they are not very much keen in treating psychiatric patient, but yes, a little bit they are motivated. So they are moderately positive attitude. And when the score comes to 49 to 96, that indicates the negative attitude. So here the students has completely negative attitude, where we have to work. We as a teaching professionals, we have to motivate our own students to treat psychiatric illness patients. So this scale was used where the minimum score was 16 and maximum was 96. And for knowledge component, we used the self-made questionnaire, which was validated as earlier said, and minimum score was 10 and maximum was 50. And interpretation was like that: 10 to 20 if score comes, that indicates they're having minimum knowledge with the for the treatment of psychiatric illness. So there is a greater room for improvement, and as score keeps on increasing, like the knowledge improves. So 41 to 50 indicates excellent knowledge. And after the data, when we have collected the data from 191 student, as I already mentioned in my previous slide, so that data was entered into the Excel sheet, and then finally we have done the statistical analysis for finding out how much problem they are having. So in this demographic details in this study was like female was 76.44%, and males were for 23.56%. And years category, like we have chosen undergraduate students, we have chosen interns and postgraduate students. So undergraduate students were 41%, interns were 30%, and PG were 28%. And age category from 20 to 22, so mainly like UG and interns comes in this category. And age from 23 to 26 years, so some interns and PG comes in this category. So it was like 43.98%. So this is the demographic details. Then coming to the analysis, this pie diagram you can see, which shows very positive attitude by a very few person. Then moderately positive attitude was there for from 57.05%, whereas negative attitude was there from 40 to 31%. So very positive, hardly just 5% of students were very positive in treating patients with psychiatric illness, whereas 40%, like almost half, just little less than half percent students had negative attitude. So this indicates that we as a teacher in the physiotherapy professionals needs to have a more
Связан с ежегодным потоком и непосредственно выезжаем из ГРДО в портал.
So distribution of students attitude according to the age. So it has been found that negative attitude was mainly seen in a patient who are having less age group. So this indicates that as the patient is getting more and more exposure, they are having more less negative attitude as compared to their less age. Okay, so 23 to 26 years age, if you see the graph, negative attitude, 35% 35% people had negative attitude, whereas in 20 to 20 to 22 age group, there were majority of the people who are having a negative attitude. Then coming to students distribution, according to the years of study. So whether they are UG or PG or interns. So this moderately positive attitude was seen mainly in case of interns, whereas a very negative attitude was seen in case of PGs, and as well as in UG students also. So interns who are relatively free from the studies, they are feeling that they should be treating more patients. So negative attitude is less in them as compared to UG and PG student, whereas positive attitude is more as compared to UG and PG students in case of interns. Positive attitude as well as moderately positive attitude. This indicates that even like UG and PG student has to study more for their exams, so for their classes. So interns are relatively free, and their aim is just to treat patients, and that may be the reason over here that they are developing a little bit positive attitude towards the treatment of patients with psychiatric illness and mental illness. Then distribution according to gender. Here we have observed that females are more prone or more having more positive attitude in treating patients with psychiatric illness, and even in case of moderately positive, they are only more, whereas in case of negative attitude, males are seen more. So this shows males are having more of negative attitude in treating patients with psychiatric illness. So here we need to concentrate on males, so motivate males further for treating this patient. Then overall distribution of knowledge. Now this attitude domain is over. Now coming to a knowledge domain. Here we can see patient has good, student has good knowledge, like almost 60% students has good knowledge, excellent, almost near about 15% has excellent knowledge. So majority of students has good knowledge and excellent knowledge about the psychiatric conditions or mental health. Uh, Then coming to the age-wise distribution, that whether they are having good knowledge or not. So as we have moved from 20 to 20 2 years to 30, 23 to 26 years, we found that as age advances, there is a matlab, if age advances matlab, they are having more and more knowledge about physiotherapy field because they have completed a UG and now they have moved to either interns or PGs, and that's why their knowledge is more in case of good and excellent knowledge, whereas young students are having less knowledge as compared to their counterpart. Then coming to the distribution of knowledge based on the year of study. So coming to UG, PG, and interns, we have observed that PG students are having excellent knowledge, uh, then or good knowledge, interns and PG students, whereas UG student, this is generally observed that UG student will have less knowledge as compared to their PGs and interns counterpart. So this is also true with this study also. Only difference I can see here that interns are having a little bit more knowledge or good knowledge as compared to the PG student. This may be because they are free, so they are free to read and they are free to understand without any compulsion of exams, any stress of lectures, attending lectures and all. So that's why that may be the reason over here. The distribution of knowledge in case of gender. Here also we observed females are having more good knowledge as compared to males and moderate knowledge. But when it comes to excellent, there is a little um, controversy here that males are having excellent knowledge, which is more than the females here. So we can say males are having more knowledge but less attitude in treating patients. And that's why when we compared this knowledge as well as attitude in correlation we tried to find out, we observed that there is a significant difference found, and there is a negative correlation exists between the attitude and the knowledge. So when if knowledge is increasing, attitude is decreasing. That is what we observed in this study, which is statistically significant, and it was moderately correlated, like the p-value, Spearman's coefficient of rank correlation, we have got R value is equal to minus 0.369, which is moderate, mild to moderate, or going towards the moderate science. So this indicates that knowledge is more, but attitude of treating patient is less. That is the main finding of this study, and we as a teacher we need to improve students' attitude, even knowledge further, and attitude by motivating them by doing more and more research on psychiatric patients and teaching them, or even we physiotherapists can go to psychiatric wards regularly, post them in a psychiatric ward regularly, and ask them to interact with the patients with psychiatric illness. So their fear, their stigma, physiotherapy stigma and fear and negative thinking will keep on reducing after good exposure of the patients. So coming to discussion of this, majority of students had moderately positive attitude with little room of improvement, followed by 40.3% having negative attitude. Good knowledge was found in 60% of students, followed by 22.51 students having moderate and 14.14% having excellent knowledge. So this study showed overall moderately positive attitude, which was contradictory to the findings of the study done by Nelly Uma Jyoti et al. In 2015, who found students with poor attitude towards individual with mental illness. This study had more number of males as compared to females, suggesting that males have more attitude, more poor attitude towards the individual with mental illness that align the current finding of our study. Our, Another study done by Prost M and J on Flemish physiotherapy students showed similar result, which states that female students had more positive attitude towards treating psychiatric illness patient with emotional and mental problems, expressing more empathic nature of females than the males influence their attitude. This study was resulted in a negative correlation between attitude and knowledge of students, which indicates that there is a big gap between having knowledge and implementation of knowledge. Direct experience is probably a more important agent of change to build and modify attitude and knowledge. And that's why direct exposure experience is very, very important. Previous researchers have identified two factors that positively influence attitude towards mental health, including length of the time devoted to teaching mental illness and modules developed to mental health, which is evident in the findings of this project, that a number of psychiatric ward placements and duration of exposure benefits the students' confidence and attitude towards mental illness. That is what even I would like to suggest here, that students should be more and more posted to such wards, and there should be more and more exposure to such students, so that their confidence and attitude will improve. So our study lists the things students have interested to know about the psychiatric illness and mental illness. This includes general idea of condition, causes, clinical features, pathology of the disease, communication strategies for engaging these clients group, and side effects of medication on physical health of such patient, that accord with the listing done by physiotherapy students across various universities in Australia and New Zealand. Students who also jotted down the need to know the patient's likes and dislikes, comfort, stresses, which shows that interest of the students, as well as support their positive attitude towards these patients. So this is very important. And then finally, I can say that it is important for students to develop a positive attitude, foster their knowledge towards patients with psychiatric disorders, to not only provide the optimum care but also boost the physiotherapy practice by exploring this domain. So this is not only a valid specifically in the context of mental health care, but also during regular practice, where patients often show psychological and psychosomatic problems. There are many patients who may come to a physiotherapy department with some other problem, like with chronic back pain or chronic neck pain. So they are also suffering from some or the other psychosomatic problems. So physiotherapists must understand the such conditions, may evaluate their depression level, anxiety level, and such cognitive levels, and start treating accordingly, even they don't come to us directly from the psychiatric reference. So it is expected from a physiotherapist to have wide range of skills for adequate practice in the market, including psychiatric skills. So various studies done before have suggested planning and formation of new curricula, including courses, lectures, and clinical practice related to psychiatry and mental health from the future physiotherapist. So this is you can include in the curriculum also about this. More and more emphasis can be given to psychiatric patients. So limitation of the study was this study was conducted to one university and does not represent the population in general. So we at the Dr. D.Y. Patil College of Physiotherapy, we are very open to conduct this study at the multi-centric level. That is what I have quoted for future scope also later. So different outcome measures can be used. Uh, mm, so making comparisons with other countries also. This will be very easy later on. Okay. And then future scope is to investigate association between hours taught, clinical exposure, personal exposure, and attitude, with attitude and knowledge. Then multicentric, as I already mentioned, that multicentric studies are very important to determine the actual prevalence of comorbid mental illness. And physiotherapy students also with comorbid physical illness related parameters were used in this. Continuous sampling again, patient assessment, all the participants and going to the organizing committee to invite them as participants. So thank you so much with this. Thank you all the physiotherapy professionals who are teaching of this. They will definitely work hard and hard towards encouraging their students in positive attitude.
Yes,
So
ma'am. So just you have got a questions from Dr. Tashibilla, madam. You can see from the in chat box the question.
I will stop sharing my and then
Yes. The question is very interesting findings on attitude and years of study. It will be interesting to find out why PG and interns have negative attitude towards mental health and psychiatric illness.
negative attitude.
Yes. Yes.
PGs are having negative attitude and UGs are having as compared to interns. Interns basically what is happening, interns are relatively quiet and they are they don't have burden of treating patients. Sorry, they don't have burden of exams. They don't have burden of attending lectures. So they can fully concentrate on study and treat the patients in various wards. Whereas PG and UG students has to give exams, so they have to study for other things also, and in terms of going to various wards, psychiatric other wards also. Similarly, they are getting more exposure in treating psychiatric patients as well as other patients. So that's why this is what we feel that they are having a little less negative attitude towards treating psychiatric patients as compared to PGs. And I think if we can do the study on the physiotherapists who have completed their graduation and their clinical practice, I think they will show more positive attitude in treating psychiatric patients. Yeah.
Yes, madam. Yes, you got, thank you. This was a compliment from Dr. Tashibullah. Thank you for insight presentation. Interesting topic. Indeed, Dr. Rati. In South Africa, we are exposing physios undergraduate students training involvement for psychiatric illness. Currently, we do not have clinical block, but they when they are qualified the work in psychiatric hospitals. I would appreciate your sharing some experience and our institution learning and our institution. This was the compliment from Dr. Tashipullah madam. Just if you have any queries regarding this topic, I request all the participants, you can mail to this email ID. You can find from the chat box. Yes.
And we are further open for doing this multi-centered study also, because many teaching professionals are here at the college. So if you are doing, we can do this study in various other institutes also and find out whether the scenario is similar all over, or is there any change in the scenario of attitude and knowledge in treating psychiatric patients. And then we can work on global platform also for treating such encouraging our students to treat psychiatric patients.
Yes. So any questions, any further questions to Dr. Manisha Rath? Any questions? If you have any questions, you can text us here so that we can ask behalf of the participants. I would like to inform to all the participants, Dr. Manisha Rath is joining as keynote speaker as well as one of the organizing committee member for this conference, and also joining this virtual event since last year, since 2020, when we got the pandemic period. This was the third conference Madam is joining our events.
I'm very much
Yes, yes,
thankful and really
yes,
appreciating your hard work.
yes.
Putting organizing.
Yes. Thank you very much, madam, for participating in this event. On behalf of organizing committee members of Virtual Physiotherapy Congress, we want to thank you for insight presentation. Thank you for joining and for your attention. Yeah, looking forward to meet again next time.
Yes, sir.
Yes, sir. Next, we asked the next keynote speaker of the day one will be Dr. Muhammad A. Takroni from King Faisal Specialist Hospital and from Research Center from Saudi Arabia. The topic will be effect of stretching on static and dynamic balance and muscle performance among young recreational football players. Sir, we ask you to start your presentation by sharing your slide.
Sure. Thank you so much. Thank you so much. First of all, I would like to thank the organizing committee actually for giving me this opportunity to share this physiotherapy and physical rehabilitation and sport medicine. I'm so grateful for that. So I'm going to go and share my slide. All right, is it okay? Clear?
Yes, it's fine.
Great. So today I'm going to talk about effect of stretching on static and dynamic balance and performance among Saudi football players. Actually, the outline of this presentation to highlight on the controversy on the effect of stretching, evidence-based of positive and negative effect of static and dynamic stretching. When should we use static and dynamic stretching, and then summary and take-home message. So talking about, stretching or static stretching, there have been controversial reports that some sport performance are negatively affected after stretching. And in recent years, stretching exercise have been an important discussion topic for coaches, athletes in terms of its impact on performance. And many researchers actually in the field of sport science and medicine have investigated the effect of stretching on sport performance. Looking here at one of the recent study, an acute effect of static stretching and muscle strength that summarized, the effect of static stretching since the World War up to day, and they, highlighted that, like, since the or after the World War, static stretching said that it's improving the athletic performance, where in late 90s up to 2000, they say that static stretching include acute decline in strength and power and should not be used. However, since that time up to 2019, static stretching has been reported to increase flexibility and prevent injury, and should be used as a fundamental part of before recreation activity, and should be used with caution in high performance athletes. Looking at the literature, this study talking about the argument against static stretching before sport and physical activity, and reported that despite early evidence that static stretching before activity did not improve performance, it remains a common element of warm-up. Another study asking, does stretching improve performance? This is a systematic review where concluded that acute stretching does not improve force or jump high. However, regular stretching improve force and jump high. Another recent study concluded that one set of short-term or long-term static stretching before an aerobic performance will not affect performance. Another one also done in a couple of years ago, concluded that our previous understanding of harmful static stretching effect on strength and power has to be updated. However, short duration of static stretching should be included as an important warm-up component before recreational sport activity. Talking about the difference between static and dynamic and which is better, this is a study on dynamic and static stretching, concluded that dynamic stretching exercise to be more effective warm-up technique than static stretching or not doing stretching. So there is a controversy here. Despite all this controversy, stretching during warm-up has become a traditional practice in preparing for exercise or athletics events. Why? Could be due to the controversy of the scientific evidence. That's why coaches and athletes still reluctant toward potential benefit and concerned when deciding whether or not to include the static stretching exercise in their warm-up program. So the aim of this study is to evaluate the effect of static stretching on dynamic and static balance of the Saudi recreation soccer player, and to verify the relationship between static and dynamic balance on athletic performance. The inclusion criteria was Saudi male healthy participant participating in recreational football player. They are not professional, but recreational. Their age was set between 18 and 30 years. They have to be practicing soccer 3 times per week, and only right dominant leg subject were selected. In the method, we were able to recruit 40 male Saudi participants, where they are randomly divided into either group A, who started the dynamic balance test first after the stretching, and group B, who started the static dynamic balance test after the stretching. The individual variable was stretching and time, and the dependent variable was static and dynamic balance. Study design. This study is a single blind randomized control with repeated measure design. Static and dynamic were the primary outcome measures, and the measures were taken 3 times: pre-stretching, immediately after stretching, and then 20 minutes after stretching. So the stretching program was performed for 3 muscle groups: hamstring, quadriceps, and calf muscles. And this stretching repeated 3 times. The holding period was 30 seconds, and there's a 10 seconds rest in between each of the 3 stretching. So here's the calf muscle stretching. So we did for the hamstring, calf, and quadriceps. The measurement tools used was the Balance Master system, which has been used to assess the static standing balance by measuring the ability of the subject to control the center of gravity over the base of support. This is a machine, and the athletes should stand here in front of the detector, which will measure the center of gravity to measure the sway. So while we use this machine, this is a valid and reliable measurement tools. The ability to minimize postural sway has been defined as postural performance, and balance has been shown to play fundamental role in many athletic activity, as well as sport specific postural control. Although the relationship between balance ability and athletic performance is less clear, but balance was reported to contribute to a successful performance. So that's the relation between the balance and the athletic performance. So here we see that the subjects were asked to stand or to step and stand still in the platform with bare feet on a single leg, on the dominant leg, and hip and knee has to be at 90 degree. The displacement of the center of gravity was measured for 10 seconds per trial, and the athlete has to be able to hold himself in this position for at least 10 seconds. And the dominant leg, as we say, that it's the one at the platform. The other hand, measuring the dynamic balance test, we use the modified start exertion balance test, which consists of 8 directions. So we have like anterior, posterior, then we have lateral and medial, and we have in between. But in this study, we used only 4 directions as a modified star exertion balance test. And the subjects or the participant were asked to stand on the dominant leg and try to reach as far as he can on the lateral side, then front, back, and the right side of the star. So data were collected and was descriptively analyzed using standard deviation. Analysis of various tests were used to compare the test score of each individual for the 3 intervals, pre, immediate, and post, for both group, and the alpha level was set at p less than or equal 0.05. The result of this study, as we see here, the demographic data of both groups are almost similar. And if we look into the result of the static balance measurement, as you see, we have group A and group B. We have group A who started the dynamic balance test first. When we put them in the measuring their static balance, we find an increase in their balance immediately after the stretching. Then they decreased back, but even their decrease was higher than the pre-stretching time. If we look here in the left side, this is the displacement time per second. So the increase in displacement means poor balance. That means those group has less balance than group B, who showed decrease in their displacement per second immediately after stretching. But we find also that they increase, they go back to just less than the pre-stretching balance. Looking at the result of the dynamic balance test for the 4 directions, anterior, lateral, posterior, and mid, we see that the pre-stretching, all the results here are less than the immediate after the stretching, and then it goes back almost equal to pre-stretching. Here in this test, the dynamic balance test, we know that the higher the number, the better balance. So we find that group A, who's starting the dynamic balance test first, have increase in their static balance immediately after stretching, and also the other group. So both groups have increase in their static balance after and dynamic balance after stretching. And here we can see the diagram for the 4 directions. We see that the blue represent the pre-stretching balance score for the dynamic test score, and the red is the the score after the this immediately after stretching. So we see the red curves for the fourth direction was increased immediately post stretching. And this is also for the dynamic balance test for the group B. They have also the same result. Their dynamic balance test increased immediately after stretching, and it decreased after 20 minutes of resting from stretching. So the result of this study demonstrate that group B, who started the static balance test first, has better balance than group A, who started the dynamic balance. And the result also demonstrate that the static stretching of the three muscle groups, hamstring, quadriceps, and gastrocnemius, has positive effect on static and dynamic balance immediately post stretching. Thus, the dynamic balance test has a negative influence on static balance test, but not vice versa. So in conclusion, here I can summarize that static stretching technique has an immediate, or we can say acute, positive effect on the static and dynamic balance of the Saudi recreation football players. However, this effect was decreased over time, and the result of the study also support the existing evidence about the positive effect of static stretching on athletes' performance. And finally, this study suggested that static stretching is useful for athletic who wish to increase their balance and visibility during warm-up period to exercise or short. Thank you so much for listening. And if you have any question, I'm ready to help.
Yes. Any questions? Any questions to Dr. Muhammad Takroni? Any questions? If you have any questions, you can text me here in chat box. We'll be asking behalf of you, even after the completion of the conference.
Sure.
Any questions? I think there is no question, sir.
All right. I hope my presentation was so clear, so it doesn't require any question. Thank you so much for listening, and thank you again.
Yes, sir. Thank you so much, sir, for joining as one of the keynote speaker for the event. Thanks for sharing your tips with us. Looking forward to meet again next time in physical event in 2022. And sir, I would like to inform you that we are going to invite you as a keynote speaker for upcoming 2020 conference, which is going to be held in Dubai. Yes, just you can see from the compliments from chat box. Wonderful presentation from Dr. Manisha Rathi as well as Dr. Tashibullah. Very insight and study needed with. Yes. Next we ask Dr. Akanksha Bajai from ITS Institute of Health and Allied Science from Uttar Pradesh from India. The topic will be prone positioning in heads. So we ask Dr. Mehta to start presentation by sharing your slide. Yes.
Good afternoon, sir.
Yes, madam.
Am I audible?
Yes, it's well.
And my screen is visible, or
Just adjust with your laptop or something from where you are going to, from where you are presenting. Just adjust with camera.
okay. Is it
Right.
fine now?
It's fine.
Okay. Good afternoon, everybody present here. Can I start?
Yes, madam, go ahead.
Okay. Good afternoon, everybody present here. I am Dr. Akanksha Bajpayee. I have completed my master's from Tirthankar Mahavir University, Uttar Pradesh, India, uh, 1 year back. And afterwards, I joined ITS Institute as an assistant professor, and I am presently working there. So, first of all, I would like to thank organizing committee for giving me this golden opportunity, uh, and uh, and congratulate them as well for presenting this beautiful idea for coming together and presenting on a virtual digital platform. So, without doing much delay, I would like to start and go ahead with my presentation. Today topic is prone positioning in acute respiratory disease distress syndrome, that is ARDS, which is so objectives of today presentation will be that I would I would try my best to give an overview why prone position is effective and its successful implementation of proning protocols during patients intubated and weak patients. So before starting the why prone positioning is important in ARDS, I would like to introduce them both as individual, like what is ARDS and what is prone position, and then after we'll talk together them. So ARDS is in 1967, ARDS is defined as an case report that described a clinical presentation in critically ill adults and children of acute hypoxemia and non-cardiogenic pulmonary edema, reduced lung compliance, increased lung stiffness, increased work of breathing, and the need of positive pressure ventilation in association with several clinical disorders, including trauma, pneumonia, sepsis, and aspiration. Afterwards, in 1992, an American and European conference established, and they have done some modifications to this definition. And in 2012, a Berlin-based definition of ARDS has come, and in that, ARDS has been classified on the basis of level of oxygenation, like mild, moderate, and severe descriptors, as you can see on the screen. Mild, moderate, and severe descriptors can added to the diagnosis of ARDS. And it depends on the clinical criteria alone because it is not practical to obtain direct measurements of lung injury by pathological samples of lung tissues in most patients. Furthermore, neither distal airspace nor blood samples can be used to diagnose ARDS. So, moving ahead, widespread inflammation of the lungs may result in a life-threatening condition called acute respiratory distress syndrome, and severe infections such as coronavirus disease, which is spreading all over the world till now, and influenza can cause ARDS. Breathing can be difficult for patients with ARDS. So coming to the prone position, what is prone position? Prone position is the technique of placing patients with breathing difficulties on their stomach or abdomen to help them breathe better. Prone positioning is generally reserved for sedated patients who require a breathing machine, which is known as ventilator, but it may be beneficial for awake patients with COVID-19. Prone position has been used for many years and is now recommended for patients with severe or moderate to severe acute respiratory distress syndrome receiving invasive mechanical ventilation with sedation and paralysis. So the question comes, why prone positioning? Why not any else position? Why only prone positioning? With the help of researchers and evidence backed in literature, prone positioning helps to improve our dependent aeration recruiting alveoli. That means it improves our aeration air exchange process, gases exchange process, which leads to reduced hyperinflation of non-dependent regions and results in more homogeneous lung aeration, which reduces regional shear strain and less ventilator-induced lung injury. Decreases barotrauma and atelectrauma. Atelectrauma, we can say opening and closing of alveoli by recruiting and reducing overdistension that occurs with higher positive and expiratory pressure, that is PEEP. Reduced PaCO2 relates to and reduced PaCO2 and which improves our dead space, decrease in dead space, and it also helps in drain secretions. Through this picture, I would like to say something that through this picture we can say we can see our heart is uh, take a look at our heart and took a look at our lungs area. Uh, the heart is putting so much compressible pressure on the lungs in supine position, and so that our our gases exchange process get so in bedridden patients so decreased, while in prone position our heart does not put so much compressible pressure on lungs, and it gives so much area to the lung tissues to provide us a good oxygenation process. So we can say prone position, possible benefits of prone position. In the supine position, the lungs are compressed by the heart and abdominal organs. Gas exchange, the process of trading carbon dioxide for oxygen, is reduced in areas of collapsed lungs, resulting in low oxygen levels. In the prone position, lung compression is less, improving lung function. This is the first benefit, possible benefits of prone position, and there are some other benefits uh, of prone position. The body has mechanisms to adjust blood flow to different portions of the lung. In ARDS, an imbalance between blood and airflow develops, leading to poor gas exchange. Prone positioning redistributes blood and airflow more evenly, reducing this imbalance and improving gas exchange. With improved lung function in the prone position, less support from the ventilator is needed to achieve adequate oxygen levels. This may reduce risk of ventilator-induced lung injury, which occurs from overinflation and excess stretching of certain portions of the lung. Prone positioning may improve heart function in some patients. In the prone position, blood return to the chamber on the right side of the heart increases and constriction of the blood vessels of the lung decreases. This may help the heart pump better, resulting in improved oxygen delivery of the body. As we have discussed earlier, in supine or prone position, how heart are put compressible pressures on the lung tissues. So due to anatomical, we can also say that due to anatomical design in supine position, the open non-dependent lung tissue is about 40% of total mass, while the dependent for the 60%. As collapse is primarily a function of the superimposed hydrostatic pressure provided by the heart, uh, while in prone, more lung tissue opens in the non-dependent zones than collapse in the dependent sternal zones. Next possible benefit may be because the mouth and nose are facing down in the prone position, secretions produced by the disease produced in the lung. That means it improves our drainage. Secretions can be drained more properly in prone position. We can conclude that in supine, marked reduction in lung volumes can be seen. Alteration in lung mechanics, lung compliance, and high resistance can be seen. Atelectasis can be seen more, and hypoxemia. Whereas in prone position, increased function, increased in and improved compliance can be seen of lung tissue. Shifting of lung water and densities, More homogeneous aeration of the lung in ARDS, more improved gaseous exchange can be seen, and increased oxygenation. Coming to the contraindications, who not to place in prone position, I have write some of them which I thought would be more relevant. First one is patients with facial and neck trauma or spinal instability. Second is patients with recent sternotomy or large ventral surface burn. Third is patients with massive hemoptysis. Patients who have spinal instability should not be placed in prone position, and patients with recent any burn injury or ventral surface burn should not be placed in prone position, and patients having massive hemoptysis should not be placed in prone position. Patients having elevated intracranial pressure should not be placed in prone position, and patients at risk of requiring cardiopulmonary resuscitation or defibrillation should not be placed in prone position. But patients having risk of CPR or defibrillation, recent guidelines of American Heart Association said that you can do your CPR in prone position also, but so this become a relative contraindication here. Patients at risk of high requiring CPR or defibrillation comes under a relative contraindication. So placement of patients in prone position, manual proning. So I have listed steps of manual proning. Step 1, with a flat sheet, pull the patient to the side of the bed opposite the ventilator using 4 staffs. The respiratory therapist should be at the head of the bed to hold the endotracheal tube. And step 2 will be place the flat sheet around the arm that will pull through side you are turning toward. Turn towards the ventilator. Step 3 would be a second flat sheet is placed on the bed and tucked under the patient. This sheet will pull through as you are turning the patient. During this lateral turn, one nurse places the electrodes on the back. Step 4, using the sheet, turn the patient over toward the ventilator and position them prone. The arm and sheets will pull across the bed. Step 5 will be pull and center the patient, discard the sheet that has used to supine patient, straighten lines in tubes, and at last check the tubes and lines that all are well together. Chest or pelvic support can be done by placing a pillow at the abdomen before completing the turn. Prone position of awake patients. While prone positioning is generally limited to patients on a ventilator, voluntary awake proning is being studied in patients with COVID-19, and these patients require monitoring for worsening respiratory status. As there are benefits of prone positioning, it also comes with some challenges. So one of them, there are some, I have listed some challenges of prone positioning. Prone positioning is considered on an individual basis. Although it is beneficial in some settings, not all patients improve and some may worsen. With changes in position, medical devices, breathing tubes, and drains may dislodge. If a breathing tube becomes dislodged, replacement in the prone position is difficult. Performing procedures on cardiopulmonary resuscitation is also challenging in the prone position and may require immediate repositioning. Also, with prone positioning, pressure is placed on the shoulders, chest, knee, and face, predisposing these areas to pressure ulcers. This may also result in nerve injury. Basically, I through this topic, I want to give an idea why prone positioning is important in ARDS. So I thought I have given that basic view that it improves our aeration, homogeneous oxygenation, it helps in drainage of secretions more properly. And if we see striking changes why supine and prone positioning is important. In the wet lung, the progressive in pressure along the vertical axis from the lung weight squeezes gas from the most dependent lung units. I guess I have completed the topic for today. So If there is any question,
Yes. Yes. Any questions regarding this topic? Any questions to Dr. Akanksha Bajaj?
Yes, I do have a question. Just asking about when we should start using the prone position. Uh, is it for any patient or there is a criteria for certain patient? This is number one. Number two, for how long um, this prone position should be done for those patients?
Yes. Did you understand the question, madam?
no, sir. Actually, can you please pardon the
Sir,
question?
just you can text in chat box, sir, so that.
I will write it down.
Mhm.
Okay, I'll write it down.
Yes. Yeah. Yes, madam. You can read from the chat box. The,
Sir, I cannot see the question here in the chat box.
when when we can start this prawn position? You understand?
Uh,
When we can start this prawn position?
Sir, we can start the prone positioning at the time we can see that oxygen saturation is falling down. For example, not in a very severe cases like in critical cases, but if we are seeing that in awake patients, if we are talking about awake patients, if SpO2 level is falling down like from 90, 85, and then 80, we can recommend them to be in prone position. And if patient is in critical condition or in ICU, we should reposition him after every 2 hours.
Yes.
I guess something is happening. I cannot see the screen properly.
This was a default from your side, madam. Just go to adjustment. And the other question from Dr. Takroni: How for how long should should
Should
be
be
used, should be used for many times per day?
Should be used for
Should be used for how many times per day?
times per a day. Sir, like in a critical patients or in bedridden patients or patients who are on ventilator, I guess every 2 hour position should be changed. But in patients who are awake, or if we are talking about the COVID-19 patients whom we are recommending more regularly to be in a prone position for maintaining their oxygen level, they should be doing it for 4 to 5 times per a day.
Okay, okay.
45 minutes per day.
Sir,
45 minutes a day.
45 minutes. 45 minutes.
Once a day.
One.
No, sir, twice or thrice a day.
Okay, thank
In
you. Thank you. So clear.
Yes. Any questions? Any further questions?
Thank you so much. So clear.
Just if you have any questions, you can text here in chat box. We'll be asking you. As because there be some audio as well as video problem due to some internet poor connection.
yes, sir. Actually, my screen is fluctuating for.
It's a default in your system, madam. Actually, it's a default from your system. From your
Yes, sir. I guess.
yes.
Just stop
I guess
stop
Zoom is
sharing.
lagging or something is happening.
Yes, sir. Go ahead, sir. Yes, go ahead. The question what you are asking. Yes, Dr. Tashibullah, just you can go ahead. The question you are asking. That's it. Okay. Yes, thank you very much, madam.
Thank you so much, sir, for giving me this
Yes,
opportunity.
yes, thank
Uh,
you for
this
joining.
was my actually first time I have given some presentation on a digital platform or in any conference. So thank you so much, sir, for giving me this opportunity.
Yes, thank you so much, ma'am, for joining as sorry, one of the speaker for this event. Thanks for sharing your tips with us. Looking forward to meet again next time in 2022. We are going to organize in Dubai, madam. It's in the month of April.
Sure, sir.
So if you willing to join this conference, you can start preparing from now itself.
Sure, sir. Sure, sir. Thank you, sir. Thank you so much, sir.
Yes, yes. You'll be getting the electronic certificate as well as booklet within 3 to 4 days after the completion of the conference. Soft copy of the book.
Okay, sir. Okay, sir. Sure,
Yes.
sir. Thank you, sir. Thank you
Yes.
so much.
Yes. Sir. Actually, according to the program, we are just 20 minutes 10 minutes ahead of actual program. So just now we got information Dr. Safana Al Said need 30 minutes. Dr. Harij Abdul Rahman will need more 10 minutes.
Yes,
So yes,
I'm here, Safina.
yes, yes, Dr. Safana, are you ready?
Safina.
Yes, are
Yes,
you ready with your PPT, madam?
yes.
Yes, just be online. Just be online.
But they just can't. Okay.
Yes, the next speaker will be Dr. Safana Hal Said from King Fahd Medical City from Rehabilitation Hospital Physical Therapy Department from Saudi Arabia. The topic will be functional functional outcome of cancer patients in an acute inpatient physical therapy. Yes,
Yes.
yes, madam. You can go ahead by sharing your slide.
So is the slides clear for you now?
Yes, yes, it's fine, madam.
Okay. Good morning, everybody. It's a pleasure to be part of this conference. Um, my name is Safana Saeed. I'm a physical therapist from King Fahd Medical City, and I'm the speaker and co-investigator of today my study presentation. And the primary author is my colleague Aman El Jouhi, also from King Fahd Medical City, Riyadh, Saudi Arabia. So today I'll present our study result with title functional outcome of cancer patients in acute inpatient setting. It's an experience of King Fahd Medical City in Riyadh. So let's go first about the background, why we choose this topic, because the global border of the disease cancer calibration statistic report that 24.5 million incident cancer um, cases worldwide, and 33% there is an increase between 2007 and 2017. And the percent of death or number of patients who died because of cancer increased up to 9.6 million per year. So early diagnosis and advances in cancer treatment have contributed to an increase in the number of the survivors. However, the lifelong physical and cognitive impairment patients with cancer experience reduced muscle strength, flexibility, endurance secondary to the effect of the chemotherapy, radiation, and surgery, or because the disease itself, and therefore it will improve or it will affect their quality of life negatively. And the quality of life is one of the leading rehabilitation concern for cancer patient and survivor. The quality of life has a positive impact by intervention of exercise to improve their functional level. So early mobilization in hospitalized patients supported by evidence and it is a useful tool to improve the patient's awareness and physical consciousness, and activity of daily living, quality of life, sleep hygiene and mood, airway clearance, and decrease fatigue. So there are many benefits of mobilizing patients in hospitalized setting, hospitalized patients. One of them is significant improvement in functional status, furthermore shortening the length of stay, and this is supported by evidence. There are two studies that suggest inpatient rehab as an intervention may lead to increased survival and reduce cancer symptoms severity. So our study objectives are to investigate the potential improvement in mobility level and quality of life during acute inpatient physical therapy from admission to discharge. So it's an acute setting, it's not a rehab setting. And also to identify the factor they may contribute to better functional outcome at discharge. So the method was to collect the data from all cancer patients referred to acute inpatient physical therapy between December 2018 to June 2019 who admitted under comprehensive cancer setting in King Fahd Medical City. And patients are evaluated or were evaluated by physical therapists within 24 hours after the referral and before discharge to home or transfer to other facility such as ICU, palliative care, or long-term facility. So the inclusion criteria, if the patient is medically stable, age from 18 and above, life expectancy according to the primary team more than 3 months, primary cancer treatment received from hematology or medical oncology specialist, and Kavinsky performance scale score 30% or more. And we exclude the patients who are less than 18 years old, diagnosis with cognitive impairment, Kavinsky performance scale definitely less than 30%, and if the patient is really sick with life expectancy less than 3 months, and scheduled for discharge within 2 days. We meant here if the patient came for admission 2 days only for chemo and then discharge. So the outcome measures that we use, 3 outcome measure. One of them is a Kavinsky performance scale, and which we'll explain after. We use it as a gold standard because we use it with the primary team, hematologist and oncologist, and 6-click basic mobility outcome measure as a primary outcome measure for functional assessment, and quality of life by using functional assessment for cancer therapy. Actually, we use the general fact short form. So Kavinsky performance score, it's 10 score with a percent from 10% up to 100%. It's explained the status of health of the patient. If the patient is healthy and has a few symptoms, moderate symptoms, difficulty in activity daily living. So you will see the patient, and generally you will assess him and score him based on the statement of his health according to the score. So we include the patient who were score 30 or more, so severely disabled, hospitalized admission indicated, but no risk of death. So maybe he's bedbound, but he's now stable and admitted to the hospital. Stable functionally, I mean the risk of death is not high. And then 6-click inpatient basic mobility score. It's a valid and reliable outcome measure used in acute setting. It measures only 6 points of function, but it's cover most of them: turning in bed, sit to stand, moving and transfer, walking, and the stair. And then it has 4 score. Either the patient is totally dependent and the maximum assistance, minimum assistance, or modify independent or independent. So it's short and to the point with 6 elements of function. So our study protocol is individualized exercise, function, and gait training, received instruction for an educational PT program at the time of discharge. So it's individualized exercise based on the patient assessment and limitation. So when it comes to our result, we received 287 patients through that period of our study. We excluded 130 due to the short life expectancy or cognitive impairment. So the included patient met inclusion criteria is 167. Okay, 10% of them refused to participate in our study. 157 accept, but 85 patients has an incomplete data, either through they discharge home without reassessment and we couldn't reach them, or the patient died during the study. And then only 99%, 99 patients, completed the initial and discharge page assessment of our study. So the mean age of the patients we received is 53 years old, and mainly most of them are female. You can see here 76 patients were female, 23 patients were male. So the mean number of sessions that received during the length of stay, 10 sessions, either to be daily or 3 times a week based on physical therapy decision and assessment. And then 26 patients were under hematology, while 73 patients under solid oncology, solid cancer, they are oncology. But first, let's see the type of cancer. Most or majority of our patients were diagnosed with breast cancer, and then second lymphoma, and then colon cancer, and then we have a different type of cancer included in our study. But the majority is breast, lymphoma, and colon cancer. So discharge destination of our patients, 82 patients were discharged home, while 17 patients discharged either transferred to palliative care or long-term facility or to ICU for or surgical ward. 11 patients, they have, from the 99 patients, 11 of them, they have spine metastasis, 9 of them, they have bone metastasis, 6 of them have a DVT or pulmonary embolism, and lastly, 6 of them have a brain metastasis, but all of them that were included in our study. So after we gave them the exercise program, and after the assessment before they discharge home, we noticed that there is an improvement, slight improvement in Kavanaugh's performance scale, but this was a gold standard just to measure the general health of the patients. So the main percent of the patients at admission, 52 percent, and then it reached to 57 percent, while it's the same state, only 10% of improvement. But interestingly, the p-value is a significant improvement. The total mobility of 6-click, the total score, the mean score is 14, while in discharge 16. So there is a significant improvement in the functional ability of the patient at discharge. While a fact, which is the quality of life, also significant improvement with the p-value result, because the total score was 13 and then at discharge 17. So this is the functional assessment of score, the three outcome measure. If they improve or not before and initial assessment and discharge. When it comes to 6-click mobility score, for who discharge home, because we mentioned that we divide them and then we will see the result. For the patient, when we took the patient who discharged home only, and then we see the effect of our statement on 6-click mobility score, we noticed that the patient either maintained their level or improved. And the improvement, we notice it more in transfer the patient. So mainly, most of them they improved in form of transfer, most of them, and walking. Also for the patient who are limited functional mobility, mainly the patient with Kavinsky Performance Scale 30%, they improved in turning and bed score at discharge with a score 4. So we analyzed the results again and again, and then divided 99 patients home discharged home and then discharged to other facility. So we mentioned that 82 patients, discharged home, while 17 patients discharged to other facility. For home discharge home, we noticed an improvement more in Kavinsky performance score, and in total score 3 degrees in total mobility score from 15 to 18, and then 1% or 110% in Kavinsky performance score, and in fact, which is the quality of life, 3 degree percent. So there are a significant improvement for a patient who discharged home, while in patient who discharged to other facility, um, we noticed that there are a decrease in Kavinsky performance scale from 41% to 35%, and this is definitely because the patient has a change in his medical status required to transfer to other facility. So it might be another one factor that affect their score. And then decline also in 6 click mobility score, and finally increase in quality of life questionnaire from 12 to 14. So in conclusion, the study suggested that rehabilitation intervention performed in hospitalized patients with cancer improve their quality of life and maintain or improve their mobility level during different stage of disease in a setting with variety of complication. But there is a limited available cancer rehabilitation in program, especially in Saudi Arabia, and it is important to integrate a cancer physical therapy model into oncology service to those kind of patients. So this program should be structured and refined for a specific group for patients with a cancer ranging from early to advanced stage of cancer, and should be considered as essential component for specialized interdisciplinary care. So thank you.
Yes.
So please, if you have any question.
Yes, if you have any questions, to Dr. Safina Al Sahed? Any questions? Even if you have any questions, even after the completion of the conference, we'll be sharing you. You can text in chat box. Yes. Just you can raise your hand if you have any questions from here. I think there is no questions, madam.
Okay.
Yes. Thank you for sharing your topic in front of this. Looking forward to meet again next time, madam.
Thank you.
Yes, also on behalf of organizing commitments of Physiotherapy Congress 2021, we want to thank you for your presentation. Looking forward to meet again next time in physical event. If everything goes well in 2022, the venue will be Dubai. Yes, you'll be getting officially electronic booklet as well as soft copy within 2 to 3 days after the completion of the conference. So this was a presentation from Dr. Safina Al Sayed. Next, we asked Dr. Arej Al Abdul Rahman from Ministry of National Guard from Saudi Arabia. The topic will be effectiveness of early physical therapy intervention on infant motor performance, comparison between input as well as inpatient as well as outpatient settings. Yes, madam, if you are in online, just you can start presentation so that we can assign you a co-host. Please let me know under what name you are in Zoom meeting. Under what name you are in Zoom meeting? Please let me know. So, or else we'll go with other speaker, Dr. Amir Falata from East Jeddah Hospital from Saudi Arabia. So no one is in online. They'll be joining after 30 minutes from now. So meanwhile, we asked Dr. Federica Pise from Paul Clinic Institute, Saudi, Celestiano from Italy to join the event and start presenting. The topic will be transcranial photobiomodulation improves perceived wellness after intensive physical activity. Yes, madam, you can start presenting.
Yes, thank you.
Yes, yes. Please,
So can you,
yes, please apologize, madam, as there some people are joining later on after your talk.
okay.
Thank you, thank you.
So can you see my slides?
Yes, it's fine.
Yes. Okay. Okay, so good evening or good morning here in Italy. It's 9 a.m. Today I'm Federica Pecci. I am neuropsychologist and I work with neuromodulation techniques. So today I will tell you something more about our study that we conducted about the use of transcranial photobiomodulation in improving perceived wellness after intense physical activity in non-professional athletes. So the use of photobiomodulation describes the therapeutic use of red or near-infrared light to stimulate healing, relieving pain and inflammation, and prevent tissue from dying. So in recent years, photobiomodulation has been applied for different brain disorders in a non-invasive manner by shining light on the head. It's a quote that I'm taking from Professor Hamblin that he uses in his paper about Alzheimer's disease and photobiomodulation. So when it is applied for brain disorders in this non-invasive manner, we call it transcranial photobiomodulation. So scientific research showed that near-infrared light absorption in biological tissues is related to some chromophores, which are able to activate the cellular signaling pathway. So light interacts with the chromophores and that are located in cells, in each type of cells. So in our case, we are talking about cells in our brain, so neurons, starting from the cytochrome C oxidase, so the CCO. This enzyme is the fourth unit of the mitochondrial respiratory chain. So what is happening is that it's the last key step of the electrons transport chain. So the photons absorbed by the CCO are going to dissociate nitric oxide that are able to promote and increase cerebral blood flow after the absorption of near light. So the absorption peak, as you can see, is in the range of the red and the near infrared light when we are talking about photobiomodulation in general. So this slide that is taken from a paper about the use of photobiomodulation in Alzheimer's disease, you can see the different mechanism that photobiomodulation presents on our brain function. So it improves angiogenesis, anti-apoptosis mechanisms, antioxidants, promotes anti-inflammation processes with synaptogenesis, neurogenesis, and obviously the mostly important when we're talking about brain disorders is the reduction of edema. So what is happening in our brain while doing physical activity and while using photobiomodulation? So the BDNF factor contributes to neurosurvival, promotes growth, survival, and differentiation of neurons and synapses, and it's expressed in our cerebral cortex and hippocampus, and is obviously involved in learning and memory. So it is known that BDNF doubles or triples while we are doing physical activity, and its level return to normal about an hour later the exercise. So the increase of its level are related to an increase in the hippocampus, which is about the 2% of the year. So moreover, physical activity increases also the NMDA receptors expression in the neurons inside the hippocampus. So the activation of these receptors increase the calcium levels inside the synapses, promoting the activation of some pathways that are regulating the BDNF expressions of proteins. So in turn, BDNF activates receptors which are present in the hippocampal progenitor cells that are promoting the creation of new neurons, as to say, neurogenesis. Another important factor is the VEGF that promotes the development of new blood vessels. So if we are increasing blood vessels and their extension of the diameter promotes a better circulation and a better brain health. So training is known to promote the production of VEGF. This is a study that has been conducted about the cerebral oxygenation during exercise, and it demonstrated that the decrease of oxygenation inside the frontal cortex is related to reduced capability of generating muscle strength. So hypoxia has deeply influenced in the study the cerebral frontal cortex oxygenation during an incremental exercise. So it is probable to say that the cerebral frontal cortex oxygenation limits training performance during hypoxia. So what is happening during exercise are different things. So the increase of cortisol levels, the expression of oxidative stress inside the basal ganglia, and obviously the changes of the BDNF. As we know from literature, a lack in BDNF inside the striatum has implication in the transmission of dopamine. And so in conditions of mobility dysfunctions related to dopamine deficiency, and as we can say, the most important disease is Parkinson's disease. So PBM can reverse many of the adverse consequences of neuronal excitotoxicity in combination with its known ability to lower inflammation, to increase angiogenesis, and to act as a neuroprotective agent. So the methods and the device that we used. So we use photobiomodulation device, of course. It's a helmet that you put on the head of our athletes in this case, and it has inside 256 near-infrared light LEDs that are emitting 810 nanometer wavelength. So our subjects, so I know it's a small sample, are 10 subjects of non-professional runners with a mean age of 33 and gender balanced. So the transcranial photobiomodulation was set after each intense training session for approximately 10 weeks per participant, and it was a treatment of 18 minutes. After each session, so after each treatment with photobiomodulation, participants were provided with a questionnaire with yes and no answers about the perception of wellness. So the outcome and the results, we had this questionnaire was aiming at understanding if there were modification between sessions and after each session, and were regarding if they were feeling more relaxed after the treatment, if they felt more anxious, if they felt more tired than before the treatment, if they had a better sleep at night, and if they felt mentally fatigued or physically fatigued. So as you can see, we have positive answers in all those aspects that are critical in recovery from intense physical activity. So they felt more relaxed, they felt less anxious, they felt more relaxed and not so tired as before treatment with photobiomodulation. They had a better sleep at night. And obviously they felt less fatigue and physical fatigue. So the most beneficial effects were, of course, for participants, better sleep and less mental fatigue. So highlights and focus points for you in this case. So it's for us a first pilot study in Italy of the use of transcranial photobiomodulation on athletes in the recovery after intense physical activity. So that's why we have such small sample. It is known for us, and it's worldwide, that sports federations aim at preserving athletes from possible damage caused by intense physical activity. Is it mentally or is it physically? So it is also known that we have neurostimulation devices such as transcranial magnetic stimulation or transcranial direct current stimulation that are methods that are used to enhance motor and cognitive skills, and that are sometimes used also in preparation for athletes before competition. So I set here an open question. So if we use photobiomodulation that is doing the same, so it improves motor and cognitive skills, would it be considered such as saying doping if we use it before a competition? So this is an open question. I know it's a wild open question about the use of this kind of techniques before physical activity, but it would be nice to share some ideas with you. So thank you for listening, and you have my contacts below, so if you would like to share an email with me, it would be nice.
Yes. Yes, any questions? Yes, any questions to Dr. Federica Pisai? Any questions? Just if you have any question, you can text in chat box. We'll be asking behalf of you, even after the completion of the conference. Yes, you can get from chat box, madam, from Dr. Tashibila. Thanks for wonderful presentation. You can get chat from chat box.
Thank you.
Yes.
So there's a message. Is it for me? No.
Yes.
Okay.
Yes, thank you very much, madam, for participating in this event.
Thank you.
Yes, on behalf of organizing committee members of Physiotherapy Congress 2021, we want to thank you for insert presentation. Looking forward to meet again next time in physical event if everything goes well in 2022.
Hopefully.
Yes, yes. So, within after the completion of the conference, within 3 to 4 days, you'll be getting the soft copy as well as electronic booklet officially through email ID, madam.
Okay.
Yes, definitely. Yes. Yes. Next, we ask Dr. Just to be on that. According to this program, Dr. Arij Al Abdul Rahman as well as Dr. Hamir Falah Tahaw should be in the Zoom meeting. Still, they are not in Zoom meeting. They'll be joining later on. As well as Dr. Anna Murray from Brazil. Is Dr. Matthew White from Physio Function for Limited UK in this Zoom meeting?
Hello, yes, I am here, but I'm still traveling to my workplace, so I can't present at the moment.
So you can take more 30 minutes, sir. We'll be inviting an alternate speaker.
Yeah, that's fine.
Yes.
Well, I won't be at my workplace for another 40 minutes, but I could present then.
No problem. No problem.
Okay.
Yes. Yes. Next, we ask Dr. Sohail Mansoor Sohani from School of Rehabilitation Science from Iran, University of Medical Sciences from Iran. The topic will be Mulligan concept of manual therapy. Yes, sir. You can go ahead by sharing your slide.
Hi, sir.
Yes, sir.
I'm ready to present.
Yes, sir. I would like to
Please admit to
I would
Share.
like
Okay.
to, yes, I would like to inform Dr. Sohail Sahoni is joining this virtual event since last 2 years, during from since last pandemic period. Yes, sir. Go
Uh,
ahead.
can I share my presentation?
Yes,
Please admit me.
just be online. I'll be going to share.
I send you my presentation, sir,
Yes, sir.
by WhatsApp. By
Yes, I,
WhatsApp.
yes,
Okay.
yes, I'm going to share you.
Okay.
So, is it fine?
Please, smaller than a screen. Okay.
Is it
It,
fine, sir?
okay, it's good.
Okay,
Thank you.
go ahead.
Hi, everyone. I'm Dr. Sohail Sohani from uh, Physical Therapy Department of Iran University of Medical Sciences. I want to explain you Mulligan concept of manual therapy. Please go to second slide. In our what's manual therapy? The philosophies or paradigm, each consisting of skills and excuse me, I want to open my presentation. Okay. Excuse me, what's manual therapy? A group of facilities or philosophies or paradigms, each consisting of techniques, skills that adhere to an adopted set of principles, theory to principles to techniques. Please go to third slide. A school of thought. Manipulation philosophies based on relieving nerve root pressure, relieving pain, normalizing joint mobility. Please go to fourth slide. A school of thought, relieving nerve root pressure. In Syriac's concept, the spinal techniques are designed to move, disc, and thus relieve nerve root pressure. Syriac's techniques are non-specific and affected many structures, including muscle and facet. Please go to 5 slide. A school of thought, relieving pain. In Maitland concept, oscillations are used to eliminate reproducible signs. The techniques are specific. In Mackenzie approach, repetitive motion is used for centralization of pain, which many interpret as centralizing the disc. Please go to, okay, thank you. A school of thought. In Kaltenborn approach, emphasis on arthrokinematic, particularly convex-concave relationships techniques are very specific. And last, Mulligan technique promotes natural apophyseal facet glides by assisting the motion being performed by the patient, usually in weight-bearing position. Go to 7th slide. Brian Mulligan is a physiotherapist born in 1954. First locum for Robin Mackenzie and Paris. Mulligan technique equals Syriac and Kaltenborn approach. Teaching Kaltenborn from 1970 in New Zealand and 1972 in Australia. Discovery of mobilization with movement in 1984 and teaching in 1986. Founding member of New Zealand Manual Therapy with Mackenzie, American Physical Therapy Association poll of the world 7 most influential persons in orthopedic manual therapy. Please go to 8th slide. How did Mulligan discover mobilization with movement? By chance, when he was treating a lady with index IP joint dysfunction, swollen and restricted flexion due to a sport injury, he treated her with US ultrasound traction and glide with no effect. Mobilization with movement provided instant, full range with pain-free movement. Mulligan concept based on number 1, positional fault, number 2, treatment plane, number 3, pain-free movement, and number 4, repetition. Number 1, positional fault hypothesis. Mulligan in 1995 proposed that minor positional fault of the joint occurs following injury or a strain resulting in movement restrictions or pain. Mulligan's mobilization can correct the positional fault and restore a restricted, painful movement to a pain-free and full range state. Measuring of positional fault is achieved by imaging techniques. There is evidence that positional fault exists at inferior tibiofibular joint, patellofemoral joint, and glenohumeral joint. Number 2, treatment plane. In peripheral joints, glide should be parallel to treatment plane on concave part. Anteroposterior glide can be used. Glide force should be close to treatment plane and in a different direction. And in cervical spine, glide force should be in the same direction of active movement. Glide can be on the superposterior or treatment plane, and changing curve involve changing in the glide direction. Number 3, pain-free. All Mulligan's techniques must not reproduce the patient's symptoms. Mild palpation discomfort might be experienced upon application of the techniques. Repetition. Several repetitions should be done during the mobilization. The purpose of simple symptom-free repetition of movement and mobilization is ultimately to sedate the CNS to reestablish dynamic natural rule of 3, 6 to 10 repetition for 3 sets depends on scene. Scene means severity, irritability, nature of pain. What's new? No pain, diagnostic and treatment tools, few minutes to decide the usefulness and long-lasting effects. Terminology: snacks, positional snacks, transverse snacks, SMWAM, MWM, and PRP. Evidence-based practice. Evidence-based practice based on best research evidence, patients' value, and clinical expertise. Please go to 18 slide. Peel. Peel response is an indication of mobilization with movement. Peel means pain-free, instant, and long-lasting. Crux rules. See contraindications of manual therapy. No absolute contraindication for manual therapy. In general, infection, inflammation, and fracture. Or repetitions, several repetitions should be done during the mobilization. The purpose of symptom-free repetition of movement and mobilization is ultimately to sedate the CNS to reestablish dynamic natural 6 to 10 repetitions for 3 sets depends on scene. O over pressure. To gain maximum movement is equal to manipulation. It's must to gain full recovery done by patients. C, communication and cooperation. Give a clear command, use an easy language, be sure that your patient is cooperating. K knowledge. Number 1, anatomy, joint planes. Number 2, biomechanics. Number 3, positional faults. And last is sustain, sense, skill, slow and subtle change. And last, principles of treatment. Number 1, do your full assessment and identify the comparable signs. Number 2, mobilization should not cause pain. Number 3, follow the treatment plan. Number 4, snacks and mobilization with movement, sustain glide, while active movement, then overpressure is taking place. Number 5, failure to improve the comparable sign would indicate the treatment plan was not correct or the technique is not fit. Number 6, look at the source of the problem. Number 7, self-treatment should be taught to maintain the results. Number 8, taping is important to maintain correction that gain from the mobilization. Number 9, if you are unable to improve the comparable sign with Mulligan approach, try another approach. Number 10, follow the rule of 3. Number 11, treatment session typically involving 3 sets of 6 to 10 repetitions. And number 12, you can always perform other type of physiotherapy with Mulligan techniques. And last, I pass the Mulligan concept by Dr. Hossein Nasser from Bahrain in my university last 2 years and do this in my clinic. Please go to last slide, please. My contact information in this slide. Thank you.
This was a presentation from Dr. Sohail Sahani. Any
Thank you,
questions?
sir.
Yes. Any questions regarding this topic? Any questions regarding this topic? Just if you have any questions, so you can. I think there's one question from sir. Yes, there was a compliment from Dr. Tashibullah. Thank you, Dr. Sohail, for the wonderful presentation.
Thanks, sir. Thanks, sir.
Yes.
Goodbye.
Yes. Thank you. Thank you very much, sir. Thank you very much, sir, for participating in this event. Also, on behalf of organizing committee members of Physiotherapy 2021, we want thank you for this presentation. Looking forward to meeting in a physical event if everything goes well in 2022 in Dubai. We are planning in for a new venue that will going to be Dubai. Yes. Next. Is Dr. What to say? Dr. Annie Murray or else Dr. Amar Falataha or Dr. Harij Hal Abdul Rahman from Saudi. If anybody are numbers, what I call you, anybody are in Zoom meeting, just you can start your presentation. Or else we'll go with Dr. Muzubake Daniel Tajbullah. Yes, sir, you can start your presentation. Yes, sir, go ahead. Yes. Yes. Now I request Dr. Muzubeke Tajbullah from Physiotherapy Department, Safikio Makote Health Sciences University from South Africa. The topic will be physical activity levels and patterns of children with cerebral palsy and the effect of intervention. I would like to inform to all the participants, Dr. Tajbullah is joining our event since last 2019. He has invited as a keynote speaker for 2019, which was held in Dubai. Yes, sir, you can start your presentation by sharing your slide.
Sorry, I was muted.
You was muted.
Are you able to see my slide?
Not yet, sir. It's going to start.
Can you see my slides now?
No, sir. Yes, it's fine, sir.
Okay, thank you so much. My study.
Okay, go ahead, sir.
Let me start my video. Sorry about that.
How are you, sir?
I am well, thank you.
I think
All right.
Yes. Go ahead.
I can start. My study is about the physical activity levels and patterns of children with cerebral palsy and the effect of an intervention. And this is part of a bigger study that I did actually for my PhD. And just a quick introduction about myself. I am a physiotherapist and I completed my PhD last year. So I'm really enjoying working with children with cerebral palsy. Thank you. Now, the one thing about children with cerebral palsy is that children with cerebral palsy, they do not engage in appropriate physical activities. And it has been shown by...
Can you please make it a full screen, if you don't mind?
Oh, let's see what's happening here. What's happening? I'll do that just now. All right.
Yes, thank you.
So evidence shows that children with CP, they do not actually engage in sufficient levels of physical activity. And what has been found especially is that when they grow up to teenagehood, the physical activity levels, they drop even more and they engage in more sedentary screen-based activities. And also it has been shown that girls show more reduced physical activity levels than boys. And also the other important thing is the importance of gender, the body mass index, and the presence of an older sibling in the family. It can help a child with cerebral palsy to engage in more physical activities. So these are facilitators in physical activities. And what we are seeing more and more with the advent of technology is that more children tend to be sedentary and they tend to engage in more screen-based physical or rather more screen-based activities than to go outside and be physically active. And what I liked in the study by IMS, it showed that actually when we look at children with CP within the school setting, the school is able to encourage children to be physically active longer. And what we also see from the study by Cullen is that children with cerebral palsy, when they are compared to their peers, they tend to be more physically, or rather they have lower physical activity levels and patterns when they are compared to their peers. And it was a similar finding also in quite a number of studies showing that when we compare the two, there are challenges. And this prompted me to then look into this whole aspect of physical activity, seeing that we have a number of children who are in special schools. And the problem statement was that the National Association for Sports and Physical Education recommends that children should accumulate a total of 120 minutes of physical activity daily. And this should be split into two. The one portion, it should actually be adult-led physical activity for about 60 minutes. And the other one, it should be just children doing free play. And research has reported that children with CP present with a wide spectrum of physical abilities, and without support, these children will not achieve recommended physical activity levels. And therefore, it shows that teachers, parents, and therapists within the schools, they will provide the adult-led physical activity for children, and that it will influence their patterns and levels of physical activity. Therefore, it became important for me to determine how, particularly in South Africa, we can influence the physical activity levels and patterns of children with CP. And in this component, the activities that were designed, children themselves had a voice in what they were doing. So in the first component of the study, we then agreed upon the various types of physical activities that they can participate in. And therefore, the intervention took a whole school term of about 11 weeks. So then the purpose of this study is to describe the physical activity levels and patterns of children with CP, particularly in Gauteng special schools in South Africa. The primary question for my study was, how are the levels and patterns of physical activity among children with cerebral palsy affected by intervention offered at Gauteng Province special schools? And this presentation focused more on the quantitative strand of the study. The aim, therefore, is to describe the levels and patterns of physical activity among children with cerebral palsy who attend Gauteng Department of Education special schools, regardless of their ambulatory status. And this became very important because a lot of studies, particularly coming from the West, from developed countries, they tend to include children who are more physically active. For example, when they use the gross motor function classification system or the manual abilities classification system, most studies include children from level 1 to level 3 who are more functional and they exclude children at level 4 and level 5, meaning children who require assistance and children who are dependent. However, with the studies on the active heart, when we check physical activity levels, even children who are dependent, when they are placed, for example, at the sports fields, we can see that their heart rate improves, it goes up, and they do reap the benefits of being engaged in those physical activities, even though it might be not at a very physical level. Therefore, the objectives were, first, to determine the participants' physical activity patterns during a weekday from Monday to Friday and a weekend, particularly Sunday and Saturdays, by utilizing the active heart rate monitors and the self-administered physical activity checklist. And for this self-administered physical activity checklist, permission was granted by Professor Salis, who is one of the designers of this tool. And secondly, it's to determine the participants' level of physical activity pre and post intervention for one school term, which was for 11 weeks. I did an extensive literature study just to understand this concept using EBSCO-host database, the CINAHL, the Pediatrics Online Official Journal database, the Google Scholar, the Science Direct database, and I used various keywords for searching. And the conceptual framework for my study, it was actually exploring the human movement, showing the two arms. If you look on your left, that's the behavioral aspects that deal with the sedentary activities, showing the discretionary and the non-discretionary activities that are sedentary. And on the other arm, it shows the physical activities that can be done for leisure, that may be occupational, such as work or school, particularly for these children, and that may be domestic, where children, for example, take part in domestic chores at home, cleaning their room and putting away their toys and being involved in other domestic activities. And the final one, it's transportation. That may include, for example, bicycling or tricycling. And on the right side, which is the main focus of this particular presentation, on the left, the behavioral aspects were explored in the qualitative part of the study, but the quantitative focused more on the energy expenditure levels, where we used the metabolic expenditure equivalents, and we then looked at the body composition and the characteristics of the children with cerebral palsy. Now, what literature showed us is that most common causes of CP, or rather cerebral palsy, is the most common cause of severe physical disability among children, and that cerebral palsy presents with a widespread spectrum where some children may be completely independent, they can be functional and taking part in athletics, they can even compete with their normally developing peers, whereas also on the other end of the spectrum, the children with CP may be completely dependent and require assistance. And when we look at the physical activity itself, we see that children with CP are less physically active, and our Versturen and colleagues, they've shown that healthcare professionals can encourage children with CP to be more physically active. And when we look at the impairments, we can see that what actually affects the physical activities, it's things like spasticity, the reflexes, the co-contraction of muscles, the weakness or loss of movement, the underlying muscle weakness, the poor or deficient sensory integration, and the poor muscle coordination and poor balance. They actually make these children to struggle participating effectively in physical activities. And what we have seen also is that some of the children, they've got activity limitations when it comes to ball skills, grasping the ball more particularly compared to throwing. They could throw once they have gotten a grasp on the ball, and it also varies. And also some children, they struggle with crawling and being basically on the floor doing mat work, mat exercises and activities. And other children, they're able to ride, but this can also be impaired by the cerebral palsy. What we have also seen is that participation for children with CP improved with physical activity on prescription, meaning that when we prescribe physical activity, it does benefit them short term, and more studies can be done to actually see the long-term effects of such. And here we have seen the classification of CP based on the diagnosis from Professor Peter Rosenbaum and colleagues. And in South Africa particularly, we are seeing a higher prevalence of cerebral palsy, where up to about 38%, or should I say, yeah, almost 30% of children presenting with CP, they acquire it prenatally, and perinatally 38%, and postnatally about 21%. And this is really serious. It shows that up to the age of 5 years, a child can be diagnosed with cerebral palsy. So Gauteng province is one of the smallest provinces in South Africa. However, it's the most densely populated. And in Gauteng province, that's where you find the capital city, Pretoria, where I did this project, and also Johannesburg. Now, the methodology for this project, particularly we used a prospective observation study over a 7-day period as phase 2A, and we also did a simple cluster randomized trial in 3 Gauteng special schools. And all children with cerebral palsy at the school were included. And the data collection, we used the self-administered physical activity checklist and the ActiHeart heart rate monitor. And at baseline, we assessed all the children, and then based on the school where they were placed, they were cluster randomized. So the one school, they had the physio that's offered at the school and physical education. The control school only looked at physical education, and the other school, we did the visual motor training and physical education from baseline assessment all the way to post-test at 11 weeks. The analysis that we used from the ActiHeart software, that's a software that we use to analyze the physical activities. And then for the SAPEC, we use the SPSS and the SAS statistical tools to analyze the findings. The key statistical tools that we used is the principal component analysis, primarily for the ActiHeart, and we used also the canonical correlation analysis, particularly for the ActiHeart heart rate monitor. And the Cronberg alpha was determined to check how reliable and valid the SAPEC tool was. And this study was ethically cleared by the University of Pretoria, and permission from the Gauteng Department of Education was obtained for 3 consecutive years of the study. And the South African Human Research Ethics Committee also gave permission, and it was registered in the database, in the national database. And only participants who signed, or their parents who signed the consent form, and the school children who signed the assent forms became participants in this particular project. Now, the findings of the study, as we can see, 65 children were recruited initially. However, 5 parents did not sign consent. And of the 60 that signed consent, a total of 7 withdrew, where 1 was withdrawn by a parent and they were relocating to another area. And another one, it was because of medical reasons. The one child needed to do a muscle lengthening surgery, and 2 didn't give reasons why they were withdrawing. And the others, they just did not complete all the tests. So particularly after we had started the project. And at baseline, then we measured 44 children who did their BMIs, the gross motor function classification scales, the manual abilities classification scales, and we also assessed their physical activities. And in these 3 groups, you can see how they were outlined, but at the end, post-intervention, we had a total of 38 children that were retained throughout the study. So the population as it stands in the 3 schools, you can see that we had more females than males, and the age of participants ranged from about 10 years to a maximum of 18 years. And what we see is that generally the females, they had a higher body mass index when compared to their male counterparts. And in terms of the characteristics of the children, we can see that about 20% of children presented with diplegia, 25% had hemiplegia, and the ataxia and athetoid groups were just over 10%. And we can see also that in terms of their devices, only 59% of children did not use a form of aids, such as either crutches or walkers or wheelchairs. And we had one child who was in a motorized wheelchair and others were in non-motorized wheelchair, 25%. So now to assess the physical activity levels using the active heart over a week period, we can see here that we can see the resting energy expenditure and the activity related. I don't see a pointer. Maybe I should just get a pointer quickly to show. Yeah, okay. So yeah, we can see here the energy, the activity related energy expenditure, and this is the dietary energy expenditure from food. And here we get the total energy expenditure and then the physical activity level. Okay, so what we then found in this study, when we look at the physical activity patterns of children with CP, we could see that on average, for the 40 children that were assessed for physical activity levels, their levels of physical activity ranged from around 1.72 during the week all the way to 1.85, which demonstrate moderate to vigorous physical activity. However, when we look at Saturday and Sunday, we can see that their activities ranged from 1.61 on Sunday and 1.70 on a Saturday. And what we like as researchers, we want to see a very small standard deviation as shown here for Monday to Thursday, which is in the regions of 0.3. However, on a Friday, we can see there's a bigger standard deviation of 0.66. And there's a reason for that I will explain just now. Now, when we look at the physical activity level metrics, we can see the correlation that Monday correlates well with Tuesday, and Tuesday correlates well with Wednesday, and Wednesday correlates well with Thursday, and Thursday correlates well with Saturday. And what we are also seeing is that if you look at Sunday, there is absolutely no moderate or high correlation with any of the weekdays. And this shows that basically the children, when they are at school, they tend to be more physically active. And on the Friday, if I can just maybe go back, you can see the physical activity level was much higher than any other day. And this could also mean that the children may be overexcited. And in some schools, it's actually a shorter day and they become even more excited for the weekend. They play more with the kids, with their peers. And that was one of the things that I could attribute to such a higher physical activity compared to other days, because children tended to play more even during recess. And when we look at the principal component analysis for the 7 days, if you can see the lines 1 up to 7, we can see at the top here on line 1, that shows that the physical activity during the week is actually very high. And this also shows also for the second line, the second component. And the two components, they actually account for more than 70% of the population. And the remaining 30% of the population, their physical activity patterns is described by line 3 up to line 7. And this was confirmed also by the script plot that we obtained when we were doing the principal component analysis. With regards to the physical activity levels in the 3 schools, we can see that children with cerebral palsy had low physical activity of up to 13.6% before intervention, and moderate physical activity of about 34.1%. However, when we compare post-intervention, we could see that there were no children with cerebral palsy who had low physical activity. And when we traced these children, we saw that many of them improved all the way up to vigorous participation. And when we see when we compare the two before and after intervention, we can see that moderate to vigorous physical activity improved to 42.2%, and vigorous physical activity improved to 28.9%. And when we look at the reliability of the self-administered physical activity checklist before intervention, we can see that for the standardized items of the SAPEC, it was acceptable. The reliability was acceptable. However, when you look at post-intervention, also the reliability was acceptable. And when we combine for the before and after intervention, the results were good. And you can see even for the standardized items, it was almost excellent at 89%. So this tells us that the SAPEC tool, which is a checklist where you just complete by ticking the activities before school, during school, and after school for children, significantly improved. And when we compare now the SAPEC with the heart rate monitor, we could see for all the children that completed that at 100% and 99%, there was a bit of over-exaggeration in reporting for the SAPEC, where the metabolic expenditure equivalence came up to 9,162 meds when compared to the heart, where the maximum came to about 4,563 meds. But if we look at the other quintiles from the 95% quintile all the way down to the lower quintiles, we can see that the heart and the SAPEC, they compare very well with each other. And this tells us that, in conclusion, children with cerebral palsy, they demonstrated improved physical activity levels and patterns following an intervention, irrespective of their ambulatory status. Number two, that children with cerebral palsy are more active during the weekdays than during the weekends. And from this, we clearly see that the school does influence physical activity participation. And this study shows that the questionnaire-based physical activity tools are cheaper and useful, and have shown that the SAPEC has a good Kronberg's alpha when focusing on the meds than when we look at the time spent in physical activities. Therefore, researchers may use other questionnaire-based tools to evaluate physical activity in children with cerebral palsy. And the most important consideration is actually the validity and reliability, or the internal consistency of the tools that one is selecting for measuring physical activity levels for children with cerebral palsy. These are some of the references that I used. Thank you very much for your attention. And if anyone would like to interact with me, my email address is this one. Thank you so much.
Yes. Any questions? Any questions to Dr. Tashabala? So, just you can...
Okay, I can see the question from Kavita.
Yes, yes.
And the question is what were scales used to compare physical activity levels? All right. Now, the physical activity levels, we actually use the self-administered physical activity checklist, and we also use the active heart rate monitor. Now, the active heart rate monitor is a small device that weighs about 10 grams, and it works more like the cardiac the ECG monitor. And it's so small that when you plug it on the chest, you can actually forget it. It uses two electrodes. It uses two ECG leads, and you can leave it on up to 21 days. But for this particular study, we left it on the child for 7 full days. They could swim with it, they could bath with it, shower with it. It doesn't get disturbed at all. And then we use a docking system to then transfer the data from the active heart into a computer, and then we use the software to analyze. And with the SAPEC, we input the information that we got from the questionnaire into Microsoft Excel, import to the statistical software tools, and then that's where we analyze. Thank you so much, Kavita.
Yes.
I hope I've answered your question.
This was the. Any questions? Any further questions to Dr. Tajabullah?
Thank you, Kavita.
Any questions? Any further questions? Yes, thank you very much, sir. We want to compliment on your topic that you choose. Thanks for sharing your tips with us. Looking forward to meet again next time in physical event.
Thank you. I'm looking forward to it again. I miss Dubai.
Yes, sir. Oh, sir, just get ready for Dubai event, sir. Hope your university as well as your faculty members will be expecting your presence to join this event.
Absolutely, sir. Thank
Yes.
you so much to the
Yes.
organizers and the fellow
Yes.
participants. Thank you.
Yes, as well as international borders also opened. So there is a Dubai Expo is going on. So we'll be following the precautions of COVID-19 as well as we'll be participating in this conference. We'll be run this conference. Yes, sir. Next, we ask Dr. Araj Hal Abdul Rahman, Ministry of National Guard, Health Affairs, Saudi Physiotherapy Association from Saudi Arabia. The topic will be the effectiveness of early physiotherapy intervention on infants' motor performance, comparison between inpatient and outpatient settings. Yes, madam, you can go ahead by sharing your slide.
Thank you very much for your introduction about me.
Yes,
I'll try to share my presentation. I have some difficulty sharing my presentation actually, to share my screen. Is there anyone can help?
Yes, you can share your PPT.
Okay. Can you see it now?
Yes, it's going to start now.
Okay, Assalamu alaikum. Welcome everyone.
Yes, it's fine.
Okay, good. So I'm going to talk about the effectiveness of physiotherapy for early intervention on infant motor performance. And we will compare it to the patients or the infants who we started from inpatient until outpatient, and compare them to the outpatient preferred patients only without starting from the in. So I'm Arij Al Abdurrahman, neonatal therapist. And I would like just to talk a little bit about our hospital. Actually, I'm from King Abdulaziz Medical City, the ministry under the Ministry of National Guard Health Affairs. And we have the KMARC, which is the King Abdullah International Medical Research Center. And I'm working in King Abdullah Specialized Children's Hospital, which we call it CASH. And we have also King Saud bin Abdulaziz University for Health Sciences. And we are waiting in the future to open the Women's Health Hospital, inshallah, in the future. This is our King Abdullah Specialized Children's Hospital CASH, which is I'm working in. Actually, this is the internal design, if you can see them. It's very nice. It's very colorful for children. My background, it looks very, very dense, but I'm going to talk about it very shortly. Early intervention is the early start of physiotherapy programs for the neonatal patients or the outpatient infants that they start with us. We are using in this study the GymFim and the GymFix, which is internationally used. And I think my colleague a while ago, he was talking about one of them. And it is well known for all the physiotherapists who are working for the motor function measurement. The neurodevelopmental therapy, which is I'm certified in, is one of the the approaches that I'm using with the patients. I'm also certified in osteopath approaches also, and I'm using the neo approach for the patients, starting from the NICU until the outpatient. Of course, we don't have a special number of session or frequency of sessions for our patients because it wasn't set as this is a cross-sectional study, and we just do a chart review for our patients to for the data extracted. And then actually we will look at the outcomes later on. So this is the GymFim that we use. It's GymFim 66 and 88. The reason why I'm using this measure, it's that it started from for children from 5 months to 16 years of age. As you see, this is the way, this is the sheet, the gross motor function measure. And this is the items that we are checking for the patient. And what I like is that it's starting from lying and rolling. And then this is the final scoring sheet that we use. And then the GymFix, also I use it as a pre-assessment and post. It gives me like a clear picture about the patient and their level. And why I choose this also because it has a before 2 years old score or classification of function. So this in the literature review, there is a huge number of studies talking about the effectiveness of the early intervention for neonates, infants since the 80s. But the problem is that some of them, they supported the effectiveness of physiotherapy, but with a lot of recommendations because there is no similarity in the methods or the outcome measure tools or the frequency, intensity of sessions. We still struggle from this because we cannot really make it standardized to generalize the results of it. So some of the systematic reviews, they said like in 2005, they concluded that the intervention was effective for infants preterm during admission at NICU, and the interventions by specific or general developmental program have a positive effect on motor development at certain age of infants. On 2012, the efficacy of early intervention program also, they said that the results also indicates the importance of physiotherapy interventions on infants, but it must be adapted individually according to the infant's age, individual characteristics. As I said, there is no similarity in the patient's age or the method or the outcome measures that it's using. I'm going to skip all of this because it will take too long. So this is a similar study to what I'm doing. It's a retrospective chart review study. They had 44 patients, they aged from 6 months to 10 years old. The patient has a special diagnosis, which is the bilateral spastic CP. They used the GymFilm and GymFix to detect the motor level. And it shows in their study that the younger the patient's age, the higher gross motor functional level they reached in gym. This is the latest systematic review. It's in 2020, and it's still not giving us a clear picture about the effectiveness of the neonatal therapy on the patient's cognition or motor and development. So talking about my PICO question, just before I talk about that, it's just to let you know that my study is not completed yet. This is what I reached because we have COVID-19 pandemic and it stopped the data collection and it stopped also the outpatient clinics, which makes it really difficult for us to finish all of the sample or the data that we are looking for. But what we can reach is a good number that I can share what we found until now with you, until this data sample is collected and the statistic part is really completed. So our population was the neonates and infants from NICU, ICN, and outpatient clinics. The intervention is the NDT and NEO model, which is the osteopathy, and the patient's family-centered care. The comparison, we compared between the patients, as I said before, who started from inpatients and continued as outpatients and the other group who started from the outpatient clinic only by referral. And our outcome is to measure the GymFin, GymFix, and see how changes that can happen between these two groups. So my question was, is early physiotherapy intervention effective on infants' motor performance if started from either inpatient and continued as outpatient, or only if started from outpatient referral only? And how early is effective? So my aim is to measure and to compare those two groups. The study setting, just not to let you confuse, we have two parts actually. King Abdulaziz Medical City, the one that has our NICU and ICN, which is the neonatal intensive care unit, and the intermediate care nursery. And in our hospital, King Abdullah Specialized Children's Hospital, we have the early physiotherapy intervention clinic for the infants and the referrals coming from the outpatient department clinic. The total sample, we had 40 until now. We excluded 2, so the included is 38 patients. And the outpatients that we got who referred to us as an outpatient, they are 18. And the inpatients who were followed until outpatients, inpatients to outpatients, they are 20. We collected their data from the charts available in our system in the hospital. We did a motor performance assessment for both groups. Each group, they have the GymFix, GymFin 1, and GymFix, GymFin 2. So it's 2 times that we took the measure. This measure, the first one is at the age of 6 months corrected age, and the second was at 18 months corrected age. So we included all the patients who are referred to us in the NICU, ICN. They supposed to be from 0 to 18 months only. Usually in the ICN, NICU, they don't keep the patients until 18 months. So we usually have them preterm babies. And usually they are about 1 month old corrected age. So our study started from 2019 until 2020. So until now, we are starting now to get up and try to have our patients follow up and try to have the data, and we will collect our data according to that. So we also included the patients who have completed data entered in the best care system. We call it a best care system. It is the electronic patient chart that we use in our hospital. The exclusion criteria is that we excluded any patient who's above 18 months, all patients before 2019 or after 2020, so they will not confuse us in the data selection. Patients who received 2 sessions only, either inpatient or outpatient, they are excluded because we cannot have any complete data. Patients who receive only inpatient session without coming to the outpatient due to some of these reasons, either the patients, they couldn't to give them a referral, or they discontinued their outpatient sessions by themselves, or the patient is under a plastic specialty like Bridget Texas patient. So this is our characteristics. We have 18 male and 20 female. We have outpatients 80 patients, and inpatients there are 20. We have, as a diagnosis, we tried to summarize how many diagnoses that we have. Actually, in the PVL, we have 2. The grade 1 IVH is 5, and 6 with grade 2, and 3 with grade 3. For the VP shunt patients, we have 4, and the seizure disorder 3, and the bronchopulmonary dysplasia is 3. We will go also to the methodology of our data selection. As I said before, we are extracting our information from the medical electronic chart that is in the best care system, entered by all healthcare providers responsible for those patients. As we said before, the age is 6 months and 18 months the assessment was. So these are the intervention, as I said before, it is used, the NDT, neurodevelopmental techniques, and the osteopathic techniques, and the patient family centered care. Our results, what we found until now, it is not final. We didn't do the final statistics. So according to the genders, as I said, for the inpatient, we have 9 female, 11 male. In the outpatient, we have 11 female, 7 male. In the GymFence score that we have and the GymFix score, okay, we have, as you know, that the GymFix, the less number or the score, it means the better the patient's independency level. On the other hand, we will talk later on about the GymFix. It is totally the opposite. So actually, the highest numbers that we have from GymFix, we have 4 and 5. We have 9 of the patients are 4, 8 are 5, scored as 5, and they are from the inpatient. Later on, when we did the GymFix 2 at the age of 18 months, the score, the patient scored with 8, with 9, they turned to 8. But the level 5 or the score of 5, they were distributed, as you see, we don't have any level 1 or level 2 patients, and we end up of having 4 and 2 without specification of the patient's condition or severity of their diagnosis. The outpatients, we have grade 3 and 4, they are the highest. 3 we have 6, and 4 we have 9. But if you go to the GymFix 2 when they are at the age of 18 months, we have the highest number now, level 1, which is the full independency of the patient, and they are 10 in number. Here it was 0, and then it turned to 10. For level 4, they were 9, but it's now 5 only. This is for the inpatient, and this is for the outpatient. I'm sorry for this very crowded chart, but just to show you some of the data that we had. This is for the inpatient gym fix for 1 and 2. The patient's age is by month. So this is patients who are 1 month old. The gym fix first, they were at level 3 and 4. And then on gym fix 2, they turned to be level 1 and 2, which is higher than before. And going also to the inpatient gym trim, as you know, the score is from 0 to 100. So if it comes closer to 100, the higher is the best in the motor function. So this is the ages. I focused on the age that they started from 1 month old, and it seems that they changed to be very high in most of them in the inpatient group. For the outpatient, we have more of 1 month old patients who are referred to us from the doctor to the outpatient clinic. And it looks like in the gym fix that they were in 3 and 4, 5 levels. And some of them, they stayed still at the level 4. Some of them, they improved a little bit, and some of them are improved markedly. Like they were the babies that they were at level 3 and 4, they turned to be 1 in gym fix, which is the best and independent. For the outpatient gym trim, we have the same patients and we did the scoring for them, and it shows that there is a little of improvement, as you see here, comparing the gym trim 1, which is the dark brown, going to the light brown core of the gym trim. I felt curious about the IVH patients that we have. We have actually like 3 patients who have IVH2, grade 2, and we have in the outpatients 3 patients also with IVH2. So I just checked that at the age of 1 month, when we did the 18-month scoring of the gym trim, we found that they have a good, reasonable improvement. For the one who started with the age 3, they have very low, and 5 have a little bit better than all of them. This is for the inpatient. For the outpatient, we have 3. The one who started at 1 month old, he reaches 39 at 18 months assessment. The 2 months old, 43, and the 4 months old, only 5, which is the lowest. This is the IVH grade 3, outpatients and inpatients. We have only here 2 patients. One started at the age 1, and he reaches 15, and the other one at age 9 months, and he reaches only 2. For also here in the inpatient, only 1 patient. He started at the age of 4 months, and he reached a very good level 86 in the gym trim. So my discussion is according to what we found until now. At the age of 6 months, most of the patients have gym fix level versus gym trim score, which is 0 to 100. We have 30% of gym trim, they have level 3. 18% of them, they are level 4, and 6% of them, they are 5. But post-physiotherapy intervention, the gym trim score increased to reach 79% for level 1 gym fix, and 42% for level 2 gym fix, 38% for level 3, and 19% for level 4, and 4% for level 5, which means that it's really getting a bit better. Most of the inpatients who started early intervention program with us improved in motor outcomes. Most of the inpatient subjects were at level 4 and 5 and improved to be distributed from 1 to 5, as we saw in the chart. Actually, in the inpatients, we didn't really look at the diagnosis and the degree of disease severity, because it for sure will affect the outcomes. In the outpatients, most of the subjects, they have level 3 and 4 gym fix, but they improved markedly to reach level 1 most of the subjects, as if you remember that they were 10 who reaches level 1. The age and the severity of the diagnosis and its complications might be, as I said before, also for the outpatients, might be an important factor in the market improvement. The two groups of patients, inpatient and outpatient, nearly equal in the age at the intervention started. Both of them, they were really started at 1 month corrected age. So our conclusion is that the early physiotherapy intervention program is very effective on infants' motor performance at the age of 18 months, if initiated at the age from 1 to 4 months. There were differences between the two groups because the outpatient group has marked improvements in the GymFix level and GymSim scores after the APS. But I cannot assure this because the data is not completed yet. The other statistic was not done yet because it was completed. The third conclusion is that the difference between the age of the two groups, it's really similar. But the severity of their diseases and the complications of it still needs to be really highly considered. So our limitation, we have still small sample size, as I told you, it's not completed yet. The data still isn't completed. Number of sessions specification is not set yet. Standardized types of intervention, transfer from camp to cash hospital. This was one of the problems that we have 2 hospitals. And patients are missed in between sometimes if the patient is discharged from the inpatient and the physicians forget to refer the patient to the outpatient clinic for physiotherapy. So they will be missed patients. Transition of all paper medical charts to electronic charts. That was a switch between 2 systems that we use for our electronic charts. We had before something called Quadramed, and now we have a best care system. So there were some of the missing parts in between for the chart. The COVID-19 has also limitations for the patients' attendance. We were really having a huge disturbance in the outpatient clinic. The continuation and discontinuation of the sessions, and there was a delay in the ethical approval for our study due to the national holidays, as you know. These are my references. And I would like really to have a special thanks for our neonatal consultant, Dr. Khalid Al-Fadloul, who supported me, truly supported me in my study. And he's still supporting me. And I wish that you interest listening to my presentation. And
Yes. So this was the presentation from Dr. Haraj Abdul Rahman. Any questions to Dr. Haraj Abdul Rahman regarding this topic? Any questions? There was a compliment from Dr. Tashibullah madam. Interesting study. We need more NDT studies conducted on infants. Blessings on completing your project.
Thank you very much. Really, really.
Yes. Any questions further? Yes. Thank you very much, madam, for joining as speaker for this event.
Thank you very much. Thank you all.
Yes. Thanks for sharing your tips with us. Looking forward to meeting again next time.
Sure. Thank you very much.
Yes. You will be getting the electronic certificate as well as electron booklet within a couple of days after this completion of the conference. Next, we ask Dr. Ana Cristina de Sao Murray from University of Sao Paulo from Brazil. The topic will be instrumentation and evaluation of measurements of MIP and MEP in the pulmonary function of people with Duchenne muscular dystrophy, a review. Yes, ma'am, go ahead by sharing your slide.
Hello. Can you hear me?
Yes, you can go ahead.
Can I go ahead? Okay. Hello, everyone. Thank you, Inovine, to having me again. And is everything is fine in there, Kevin, please?
Yes, you can start
Yeah?
sharing this. Yes.
Is that okay? Everything is fine?
Yes, it's fine, everything.
Okay. So thank you, Inovine, to having me again. And thank you, everybody, to hear me this morning. My presentation is part of my thesis, the ones I'm developing in Brazil. And the laboratory in Brazil has the many concerns about how to test the lungs problems in Duchenne dystrophy. So what I'm going to present today is related to the problems we got when we measure the pressures inside the lungs of these children. As we know, the decrease in the pulmonary function in people with TMD contributes to the significant due to the progressive weakness of the respiratory muscles. As a physiotherapists are the movement experts, which include respiratory assessments, who optimize quality of life and through the prescribed exercise, evaluation to the quality of respiratory movement, other respiratory sessions, hands-on cares, and also the patient education. So as a physiotherapist, we teach patients how to prevent or manage their conditions so that we'll achieve kind of long-term health as we can with these children. So the collaboration with our children and their families and all the group involved with the treatment of them are important. Then, always when we think about to evaluate these children, we think which is more important, knows about the flow or the pressure is what is flow inside the lungs. When we refer about the Duchenne, we always think about pressure. Why? The weakness muscles that cannot have the strength to put the air inside. So if they don't have the strength to put the air inside, we have troubles to get all the liquids and things we have to expel from them. Another thing is these children evaluate really quick and for dependent from anyone. So the classic signs of GMG is the difficulty to lift the head or neck, which really contributes for the poor breathing patterns. And they have a walking with the chest pointed out or sway back or even sandal back and sometimes arch back. That is a really bad posture for someone needs to, doesn't have strength to breathe. Then we need to evaluate how these lungs can change and ventilate the air, which doesn't mean they got lungs problems. They just don't have the strength to put the enough air in and also to take the enough air out. As we know, the muscle weakness in these children develops more proximal, closer to the trunk. They first lose the lower extremities, but unfortunately, quite quick and progressive, they start to lose the upper extremity. So important to maintain the air flowing and the quality of the clean lungs. Well, the characterization of respiratory function of this population is well described worldwide using the pulmonary function tests with specific instruments that include measurements of maximal respiratory pressure. Okay, but then we just discussing in this paper we wrote, we've been researching that for long. We already got some equipment a little bit more accurate to use with this type of children. As I have to reinforce the idea, they have a weakness muscles and they have troubles, including to put the mouthpiece and to keep them closed and to not leave the air escape during the test, which really makes them trouble to understand the results. Another thing, we already got some predictive formulas specific for neuromuscular disease we should use during our sections or evaluation when we study the capacity of their lungs. The roles of physiotherapy is continue to expand, focus on maintaining breathing exercise to keep their lungs healthy as we can and maintain independence. So that is a gold standard to provide a good physiotherapy for these children. Then, I'm sorry, right. Then the assessment and measurement of this pressure are clinical relevant for us and necessary for the therapeutic adequacy. As there is no standardization in the protocol of the equipment to be used, and there is great variability between the evaluation. Again, we have so many numbers to understand, and the children become, and on brackets in there, number. So, which is more important is to keep your eyes on the function. The function is important, not the number we evaluate into. I explain myself. What happens is we can have children with Duchenne dystrophy, muscular dystrophy, with 7 years old and already in a power chair and a mechanical chair, as we are in Brazil, and some adolescent with 16, 17 years old is still using walking sticks. So again, age is not the red flag, it's function is the red flag. So in this article, we demonstrate this and suggest follows the protocol already developed by European and American Thoracic Association and the Brazilian consensus of spirometry, which is also based in the formulas developed from Knudson since 1976 and appropriated from Wilson 1984, so it's long ago, to patronize, to make the standard formula, the standard predictive formula to evaluate these children in a clinical evaluation. The objective of our paper, we try to identify and characterize the main criteria and instruments for evaluation between maximum inspiratory and expiratory pressure in pulmonary functions of people with Duchenne. We analyzed 85 papers all over the world, all worldwide, and with analytical bibliographic review of these scientific articles, and was divided in 4 phases: collection, selection, tabulation of data, and characterization of evaluation instruments, which is extremely important. Why? If we want to really, rise the idea, we have to look through all the papers being written the past of 10 years. In the past of 10 years, we can find 85 articles all related to that function, to evaluate the pulmonary tests. And the results of this research, we tabulated according to the number of patients, objective inclusion criteria, and evaluate instruments, which, as I said, including not just the lungs tests, but also which kind of medical equipment they being used. Then, showing that table, the first work is our research in Brazil. We've been looking for 231 children between 9 and 8 years old. And comparing to the other researchers all over the world, our number of subjects are really high up than the others. And all these authors, Nicole is from Italy, Ken is from America, Bath, America, Steyer, German. All of them not just study their own population, but they study all the population inside their own countries, which means is a really high variety of people being studied. We don't know for how long we can really rise this flag, but I think it's interesting to someone really works with respiratory physiotherapy with that type of analytic tests, look through that and rethink how to use the formulas. Although all this, the numbers are really similar between our study and the study all of the world. In another side, we've been studying as well as the Brazilian population. So by study inside the Federal University Brazil and the other studies all over Brazil with different populations in different states or different councils in Brazil. So we got the same pattern and more or less the same numbers. And my purpose in here, because I don't want to talk about problems on top of problems. Actually, I've been just trying to think with a whole physio researchers, why we don't standardize the instrument. What I mean is the equipment is really simple equipment we use. Don't need to be too expensive, can be a simple ones, can be analogical ones, hand ones, and make a respiratory consensus of neuromuscular evaluation criteria for all of us. As we have got so many protocols to do in so many disease or in so many type of tests, I'm not saying it doesn't exist. I'm just saying we should look through and use specifically when we're doing the tests. And of course, that will give the physiotherapy data assessment more independence and reliability and scientific parameters to carry on their section day by day. That is a purpose to normalize these patterns and equipment. As I said, there's really simple and hands-on equipment, can be analogical. We don't say to make the full learn tests. I'm just saying, sorry, to make the assessment, the measurement day by day or at least weekly when we're going to see your patient. So the conclusion of this research, after read and compare 85 papers, scientific papers all over the world, the objectives are achieved. And unfortunately, there was not a single standardization among the articles studied. Only one used the evaluation criteria for people with neuromuscular disease described by American Thoracic Society, and none follow the standardization of instruments. I make to clarify this point. When I say standardization of instruments, we just want to say like you use a monovacometer, peak flow meter, speedometer, but then not start to use loads of pieces and bubbles and water, something like that. You just make simple to be simple but scientific. However, the evaluations that we are done, which we are developed with standards for non-sick people, are still option for correlating a standard for assessing respiratory function in patients with DMD. That is the main point. I'm evaluating sick people with the major problem at this point is the weakness muscles. They don't have strength to breathe. So I can have the whole air flowing freely in their lungs because they don't have muscles to put them out, and depend on their phase of the disease, they don't have strength to put the air in. How can I compare the numbers I got in a non-sick people with someone who's already sick, which is doesn't really gave me weird numbers in a way to, if a healthy people, we expect 200 meals, and with addition, he's watching 160 meals will be absolutely astonishing for their quality of life. So as that is the point. And also, if we already got all the standards for the instruments and the numbers to apply in the lung tests, why we can? Well, yes, we can. We can make their lives more comfortable and also make the physiotherapist day-to-day practice more efficient and with scientific support. And again, I need to say again, I'm not saying we are not scientific. I'm not saying we don't have all the formulas and the way to do. I'm just giving the idea we can make simple and better for the patient and the physiotherapist community to not just evaluate it and evaluate this student, but also to help us to work a little bit more freely. And just for curiosity, in Brazil, we got a children's cartoon who describe our one children attracted with Duchenne muscular dystrophy to teach the community how this disease developed and is unfortunately exists and how to deal with. Is anyone interested in read all my article, the full article? That is the address. I'll be very proud and everybody is very welcome to read. It's in a Brazilian journal, but it's in English version. And thank you ever so much, Inovine, for having me again, and all the people hearing me now. And that is my email address if anyone will want to interact with me or have some questions, please contact me.
Yes, yes. Yes, any questions? Any questions to Dr. Anna Murray? We would like to inform, sorry, I would like to inform that Anna Murray is joining our event since last 2 years.
Yes.
Yes, as one of the speaker for this conference, and encouraging this kind of scientific events to get awareness among all the physiotherapists.
Thank you ever so much, Bobby.
Yes,
Thank
yes, yes.
you.
I think it's early in the morning in Brazil, I think.
It's okay. It's 5 o'clock in the morning in Brazil, but I'm still happy. And I'm really proud to be here. It's just for strong people.
Yes, please apologize. We have disturbed you.
No problem. No problem.
Yeah.
I told you I can handle it. It's
Yes.
important for all the scientific community. Thank you
Yes.
ever so much.
Yes. Any questions? Any further questions again? Yes, thank you very much, madam, for joining as a speaker for this conference.
Thank you again.
Yes, thanks for sharing your tips with us. Looking forward to meet again as one of the keynote as well as expert speaker for upcoming 2022 event. So we are expecting, yes, we are expecting you as one of the keynote speaker for upcoming Dubai event.
Thank you for the invite, and I accept it.
Yes. Yes. Within couple of days, you'll be getting officially the electronic booklet as well as your participation certificate through your email.
Okay.
Yes.
Thank you.
Yes.
Looking forward to.
Yes. Have a nice day, madam. Very good morning as well as have a nice day.
Thank you. Bye bye.
Next, we ask Dr. Matthew White from Physio Function Limited from United Kingdom. The topic will be effectiveness of dynamic press therapy enhanced exercise program on joint and balanced in a adolescent with post-rate fossa syndrome, a case study. Yes, sir, you can go ahead by sharing your slide.
Okay, is that showing on the screen for everybody?
Yes, sir.
Brilliant. Well, good morning from the UK. Not quite as early as 5 o'clock, but it is still the morning over here. My name's Matt White. I'm a physiotherapist. It's very kind to be introduced as doctor, but I'm not doctor. I am working for a specialist neurorehabilitation outpatient clinic in the UK, and my specialist area is the integration of rehabilitation technology into neurorehabilitation. And today we're going to discuss a relatively new concept, certainly to UK practice, of dynamic pressor therapy and its application with a young man with posterior fossa syndrome. So my aims for today are to answer what is posterior fossa syndrome for those who haven't come across it before, and to describe what is dynamic pressor therapy, and then to present our case study and share the benefits of incorporating this technology into neurorehabilitation practice for this patient and for the wider population. So what is posterior fossa syndrome? Now, this condition develops in approximately 25% of children who are diagnosed with medulloblastoma. Now, the incidence of medulloblastoma is around about 1.5 to 2 per 100,000 of the population. So we're talking quite low instances, with approximately 100-ish cases affected in the in the US each year. It can also be known as cerebellar mutism disorder, and primarily affects the cerebellum, the pons, and the medulla. So the consequential symptoms predominantly are weakness affecting one side of the body, a loss of speech and difficulty swallowing, facial paralysis to one side, ataxia, and also problems with memory. Dynamic pressor therapy is a relatively new concept, as I said, to certainly neurological practice, and it's defined as the movement of compression and decompression in combination with physical activity at different intensities in order to enhance venous return. This is very different to passive pressor therapy, which is commonly used following sports injuries as a mechanical drainage technique. to try and reduce swelling. And the combination of the physical activity with the dynamic pressor therapy is believed to accelerate lymphatic system activation and promote healing, improve muscle activity and tone, and also aids to renew mobility. Now, this therapy is kind of born out of the sports industry, and so relatively recently stepped across into neurological practice. It's believed to work upon 4 primary effects. The first being stimulation of the skin's baroreceptors to enhance the individual's attention to the area that is being compressed. The second is facilitation of motor unit recruitment to help try and enhance the strength of contraction that an individual is able to produce. The third is an enhancement of mechanoreceptors in the fascia and the muscle tendons, which are crucial to our proprioception and muscle control. And the fourth is promotion of venous return to reduce swelling, reduce pooling, and improve limb activity. So hopefully we can see that from those 4 effects, this is going to have a significant effect upon the majority of our neurological patients who have difficulty recruiting their motor units, have impaired sensation, and also commonly present with impaired proprioception. And the combined effect for all of these 4 effects is improved targeted attention, improved proprioception, and more effective contraction, which ultimately is leading to better function. The current evidence is largely anecdotal and certainly non-controlled at the moment. There's been some small numbers of studies, or case studies presented with Ehlers-Danlos, using a continuous level of compression at around about 50 to 70 milligrams of mercury, and seen that there's an improvement in the maintenance of joint position sense, improved pain, and improved functional walking and physical activity. Expanding into Parkinson's and multiple sclerosis, using a sequential compression technique, we've seen improvements in their function in a get up and go test, again with improved proprioception and improved exercise endurance with reduced post-exercise fatigue. And then finally, there's multiple patients that we've seen within my practice using moderate level pressures for continuous effects, generally looking at postural enhancement, greater awareness of the lower limb, improved stability of knee and hip control, which is then ultimately leading to improved gait and improved function and exercise. So we've been delivering dynamic pressor therapy via the GMOVE suite, which is a relatively low cost piece of equipment for neurological rehabilitation technology, and involves a compression unit that is worn on the front of the body and then weighted down through the belt behind. It weighs around 1 kilo, so the individuals don't feel this weight passed through them significantly when they're exercising with the device. And it can deliver pressures from between 30 milligrams of mercury, which is approximately the level that you would get with a compression stocking, up to 120 milligrams of mercury, which is beginning to step into the realms of blood flow occlusion, and I'll discuss that a little bit later. There's a universal belt attached with the system that basically supports the 2 leg cuffs, and it's a one-size-fits-all system, so there's quite a wide range of the sizes that this will accommodate, and it also has attachments built in for the hanging of the compression unit from it. And then the left and right compression sleeves have chambers within the thigh area and the lower leg area that just run through as a continuous or intermittent pressure. So we would select the pressure that we desire within the compression unit, and then that would apply to both cuffs in both the below and above and below knee areas at the time. So we can apply the GMOVE via 3 different programs. The first one is named Restore. This involves predominantly applied for rest and recovery, where it will compress through the lower leg, then it will release, then compress through the thigh, then release and work on a cyclical manner. So we're enhancing blood flow, and we're allowing greater drainage of tissues. The second is kind of active mode. Now this is commonly used within the sports industry to work for short periods of time with compression, and then reducing the compression off for rest periods. And this will involve a compression through the calf initially, then moving up into the thigh area where they will hold for a set period of time, and then both will release, and it will continue on in a cyclical manner from there. And then the final program that we use predominantly with our neurological patients is termed Boost. Now, this is simply constant compression applied through all 4 chambers of both limbs, or unilaterally, if you so desired, to just not attach one of the cuffs onto the device at the time. We have taken this approach predominantly because we're giving this constant level of attention to the individual. So rather than having a cyclical and variable approach to it, it's giving them that constant education, that constant reinforcement of their muscles and of their sensory system. And we're using, as you saw in the table previously, moderate pressures of approximately 50 milligrams of mercury as a start point. And we found through our clinical practice that this provides us with a really positive effect upon proprioception and awareness, but without impacting blood flow. Now, the important distinction here is that when we start looking at blood flow occlusion therapies, this is designed to try and encourage a muscle to work in an anaerobic environment. So it preferences the type 2 muscle fibers, so it develops greater levels of muscle strengthening. This has been shown to be quite effective in elderly populations and in sporting populations. However, because we're working with predominantly patients who've got some degree of cardiovascular compromise, it's still unclear as to the specific impact on their cardiac functions. So a little bit more research is required before we start delving into blood flow occlusion therapies with our neurological populations for myself. But certainly with lower levels of pressure, we're seeing some really, really nice improvements in proprioception. So I'm going to present the case study of Mikey, who is a young man who was diagnosed with medulloblastoma in 2007 when he was 7 years old. It's very common for children of this age to be diagnosed with medulloblastoma. I think around 70% diagnosed underneath the age of 10. So over the preceding, the next 7 years, Mikey's had various treatment interventions, inclusive of multiple surgeries, a ventricular peritoneal shunt, various courses of chemotherapy, and he even attended about 3 months in the United States to have proton therapy in an attempt to shrink his tumour. But unfortunately, all of these treatments were ultimately unsuccessful. And after a collapse in 2015, he required emergency surgery to excise as much of the tumour as possible. And this resulted in him suffering from posterior fossa syndrome. So his main presentation and his main symptoms include ataxia, slurred speech, and weakness, predominantly affecting his left leg. Now, treatment to date, he's attended physiofunction for around about 7 years, and he's had various different therapeutic interventions that are focused around his static and dynamic balance, proprioceptive training for both his upper and lower limb, core stability training, gait re-education, muscle strengthening and strengthening, and cardiovascular training. And at the beginning of our sort of clinical field test with the G-Move for Mikey, he was able to walk with a gutter frame with supervision, and then he was able to walk over ground with the assistance of one person with no walking aid. So for our dynamic pressor therapy intervention, we performed baseline assessments using a Tonetti performative orientated mobility assessment in the clinic at the beginning. Now this is a simple clinical tool that uses 2 components. One is a static and dynamic balance component, and the other is a measurement of various different gait components and gait parameters that we can observe quickly and easily within clinic. And we chose this one because it's quick and easy to apply. It doesn't require any special tools, and the minimal detectable change for this tool is between 4 and 6 points out of a total of 28, depending on the condition. Now, there's no specific level being published for posterior fossa syndrome, but certainly working within that 4 to 6 point range gave us a good indication of clinically relevant improvements for him at the end. So we applied the G-Move suit using boost mode with a pressure of 50 milligrams of mercury. And he was then sent home with this suit for 5 weeks and asked to do 5 sessions per week, 30 minutes of an exercise program involving exercises like lunges, squats, standing balance exercises to strengthen his lower limb and improve his balance. And then also complete 30 minutes of supported walking with his parents each day during the week. He also had 1 session per week in the clinic using the G-Move suit, working on enhancing those balance activities and increasing his walking ability. The POMA was then repeated 5 weeks later, post section, and then the G-move was removed from his home-based setup, and he was then asked to continue on with the exercise program as much as possible, and then we repeated the test again 4 weeks later, where he basically had his exercise program and previous regular therapy had resumed. So for our outcomes, we found that his adherence was really positive throughout the entire 5-week period using the G-move suit. However, during the 4-week follow-up, he had a significant reduction in his exercise and also suffered an unrelated foot injury requiring a 2-week absence from regular therapy. So within our very short window of follow-up, there was a significant drop-off in his levels of physical activity. However, when we look at the graphs demonstrating our improvement levels, we can see that between our pre and post section, so over the 5 weeks of intervention, there was a large change of 6 points from a score of 18 up to a score of 24 following the intervention. And you can see from the breakdown of the graph here that it's a significant increase in his balance component. So static and dynamic balance improved significantly following the use of the G-move and the application of the exercise program. And then 4 weeks later, despite the significant drop off in activity, he still had a 4-point increase from his baseline levels. And this has actually continued up to this date. So this trial took place around about 7 months ago, and he's still attending regular therapy and is still operating at a higher level of function and balance following on from the G-move sessions. And useful for him, his fall risk also reduced from a registered level of high through the Tenetti program down to moderate. So we saw some really sort of clinically meaningful changes for him as part of the use of this technology. I'm going to just share a little video that was taken during the final session. So you can see here that both myself and my colleague Claire, who was his primary therapist, are closely supervising, but he's now walking across the gym without any physical aid. Unbalanced and quite a deviated path. But he was then able to walk independently, which was something that was not achievable for him prior to beginning the G-move sessions. So within 5 weeks, we saw a significant improvement in that walking function. When we did our POMA assessment, his walking was assessed using his gutter frame. So it wasn't done independently. He did have a walking aid at the time. So subjectively, he told us that he felt that he could move more independently. He also felt that he felt safer and stronger through his leg muscles, and he felt that he could stand up better. So subjectively, he really bought into the therapy and he engaged with it very, very nicely, and he felt that he got a significant benefit from the use of this dynamic pressor therapy. So in conclusion, we observed a clinically meaningful improvement in Mikey's gait and his balance after the 5-week pressor therapy enhanced program. We still saw some improvement maintained despite a significant reduction in activity. And we found that the addition of the dynamic pressor therapy to his program significantly enhanced his adherence to exercise out of clinic, and it improved his ability to balance and walk independently, way beyond what he'd been able to achieve previously within 7 years of physiotherapy. But the impact of this to the wider context is that within our clinic, we've used the G-move suit to deliver dynamic pressor therapy with multiple different diagnoses of patients. So in the images you can see to the side, we have a young lady with functional neurological disorder. We have a gentleman with MS, and we have a gentleman who suffered a stroke. Mike's experience has been mirrored by many of these other patients. So whilst the improvements we've seen within him have been fantastic, we are seeing similar effects with patients across the board from various different neurological conditions, various different levels of function, and various different levels of acuity of that condition as well. And we believe that the use of the dynamic pressor therapy within the therapy sessions, both in clinic and at home, has the potential to enhance the function, mobility, and engagement of patients with posterior fossa syndrome and the wider context of neurological rehabilitation. So for further information about sort of our clinical use of the GMU suit and about dynamic pressor therapy, my details are on the left-hand side there. And I've also included the contact details for the local representative within the UK for the company that provides the device. So if anybody is particularly interested in learning some more about the device itself, then they can make contact with Sam Wood, who can then direct them to an appropriate contact within their local area and country. Many thanks for listening.
Yes. So this was the presentation from, shall I call him Mr. or Dr. Sir?
Go, Mr.
I'll be calling better Sir.
That's fine.
Yes. This was a presentation from Sir Matthew White. Any questions regarding this topic? Just if you have any questions, you can text here in chat box. We'll be asking you. Just you can raise your hand if you have any questions. Yes, sir. Go ahead.
Thank you so much for the insightful presentation. The GMOOC suit definitely shows good case study results, but I'm just wondering in terms of cost, how much are we looking at roughly at the moment? Thank you.
Sorry, I couldn't hear your question very well. The line is not very clear.
It's not clear, sir. Just you can repeat again.
Okay, I'm asking about the cost.
You can text in chat box.
Okay, I'll text. How much is it?
How much is it? So in pounds in the UK, it's 2,500.
Okay, thank you so much.
You're welcome.
Yes. Yes, thank you so much, sir, for joining this event as a speaker.
Thank you very much. It's been a pleasure.
Thanks for sharing your tips with us. Looking forward to meet again next time. And
Thank
one
you.
more thing, sir, just we can add to your organization, that is Physiofunctional Limited will be adding as your logo as one of the media partner for this event, for upcoming events, sir, if you give permission.
Yes, of course.
Yes, definitely, sir. So as soon as completing this conference, you will be getting electronic certificate as well booklet within a couple of days after the completion of this conference.
Thank you very much.
Yes. Thanks for your patience, sir. Please apologize if everything goes wrong from our side. Yes.
Thank you very much.
Have a nice day. Bye.
And you enjoy.
Yes. Next, we ask Dr. Amar Falatha from East Jeddah Hospital from Saudi Arabia. The topic will be effect of tele-rehabilitation exercise program on pain and functional ability in patients with neck pain. Yes, sir. You can go ahead by sharing your slide.
Hello?
Yes, sir. Go ahead.
Okay. My topic today about telerehabilitation exercise program on pain and functional ability and in patient with neck pain.
Okay, it's fine.
Okay.
Yeah, it's fine, sir. Go ahead.
Okay. My topic today is effect of telerehabilitation exercise program on pain and functional ability in patient with neck pain. The objective to define the telerehabilitation, to enumerate the importance of telerehabilitation, to discuss about the material and methodology, to explain the analysis and result, to describe future implementation of telerehabilitation. Introduction. Musculoskeletal disorder are considered as life-threatening and will restrict daily activities, result in a change or discontinuation in life. Neck pain is one of major problems that affected people in part of their life. More studies recommended that the neck pain was most popular in middle age, and the prevalence of chronic neck pain may vary. Significance of this study: in risk scenario with COVID-19, many people were suffering from physical and psychological conditions, social life. The factors that contribute to delay of physiotherapy involve an overall evaluation process targeting the quality and safety of patient care, can improve the country healthcare system. The effect of telerehabilitation on patient care quality has rarely been studied. Therefore, the present study has major significance to assess the impact of telerehabilitation on patient care quality. Telerehabilitation for neck pain may be viewed as a significant measure of patient care quality. Review of literature. The literature was collected from various journals and internet sources. The review enabled the investigator to gain deep insight into the methodology content. The literature helped to support the study finding and determine the effectiveness of information. Research methodology. Research approach. The present study intends to assess the effect of telerehabilitation exercise program on pain and functional ability in patients with neck pain. Research design. The subject was assigned into one group pre-test, post-test design, quasi-experimental. The design aimed to provide a sufficiently complete description of what is happening at a particular time. Research methodology study setting. The study conducted at orthopedic clinic in western region of Saudi Arabia. The target population consists of all patients with neck pain at orthopedic clinic in western region of Saudi Arabia. Sampling method. A purposive sampling technique was used to collect the data for patients from orthopedic clinic in western region of Saudi Arabia. Instrument. Assessment sheet, numerical pain scale to assess pain, and neck disability index to assess the functional ability for patient. Zoom video conference and personal computer were used to assess the impact of telerehabilitation exercise program on neck pain patient. Telerehabilitation exercise program include active range of motion exercise, stretching and strengthening exercise for neck. Analysis and result. This graph is the distribution of patients based on the age group. This figure distribution of patients based on profession. We had a teacher, the administrator, the student, and one patient no work. This distribution of patient numerical pain score based on pre and post test. This figure is distribution of patient neck disability index score based on pre and post test. The result. The pre-numerical pain scale score for patient was associated with mean of 4.5, standard deviation 2.03. By comparison of post-test was associated with the mean 3, standard deviation 2.03. To the t-test hypothesis, the pain score, the pre-neck disability index score for 4 patients was associated with mean 6.25. Standard deviation was 4. By comparison of post-test was associated with mean 5 and standard deviation was 4. Discussion. Our discussion, the overall aim of this study is to measure effectiveness of telerehabilitation exercise program on pain and functional ability in patients with neck pain. Findings of this study include 4 patients were participated in this study. 3 among the patients showed improvement. More one among them pain score and net disability became 0 after post-test, whereas one patient increased numerical pain and net disability index scores after sessions. The limitation of our study was limited to patients who came to participate in this study. The small sample size, another challenge because of COVID crisis. Our study only showed the patient with neck pain, although we did not observe for other diagnoses. The study conducting among male patients only. The patients are willing to participate only the part of the study. Furthermore, due to COVID-19, the number of patients at this study was low. Conclusion. The use of telerehabilitation was associated with minimize the time, expense, and inconvenience of receiving rehabilitative care. The result indicates that telerehabilitation promising potential alternative standard of care, although some factors like unavailability of internet and material will negatively affect the therapy. The exercise program is important to treat patients with neck pain, and furthermore, the treatment session should focus on specific cervical muscles. Implication for future research. The similar study can be conducted on large sample for better generalization of finding and can be choose other diagnosis seeking physiotherapy. The healthcare organizations should develop and implement the telerehabilitation strategies. Most of reviewed literature pointed to importance of ensuring an adequate level of rehabilitation based on experimental design. A physiotherapist need to more technical skills in both pre and post-test time, and more often need to do periodic assessment with each session. This are our references. This is in this study. Thank you for listening.
Yes, sir. This was the presentation from Dr. Amar Falataha from Saudi Arabia. Yes, any questions regarding this topic? Any questions regarding this topic? So I think there is no question, sir. Thank you very much, sir, for joining.
Thank you.
Yes,
thank you for inviting.
Yes, thank you so much for joining this event as speaker for this event. Thanks for sharing your
Thank
with us. Yes, looking forward to meet again next time, sir.
Sure.
In physical event 2022.
Thank you.
Yes. Yes. According to scientific program, we need to have it's 3 o'clock according to Indian timings. That is Dr. Edonos Supaji from Albania, Dr. Justin Benoit from Canada, Dr. Sheila Rohane from USA, Dr. Sheila Thielin from USA, as well as Dr. Angela Sale from USA. We have more 4 more talks for end of this day 1 session. So next we asked Dr. Yes. Next we will be going with Dr. Edonos Supaji from Radiology Department, University of Medicine from Albania. The topic will be MRI diagnosis and paraneoplastic trigeminal neuropathy and rehabilitation.
Hello. Today I would like to present a video webinar on MRI diagnosis, paraneoplastic, trigeminal neuropathy, and rehabilitation. In the beginning, we have some introduction words about trigeminal neuralgia. Trigeminal neuralgia, or tic-Dolorex, corresponds to a clinical manifestation of sudden severe paroxysm of excruciating pain on one side of the face, which usually lasts a few seconds to a few minutes, involving one or more branches of the trigeminal nerve. The most prevalent cause of trigeminal nerve is vascular compression. Other causes include compression due to cerebellopontine angle, that can be tumor or cysts, perineural tumor spread, or multiple sclerosis. Here we can talk about the importance of MRI in trigeminal nerve. Prior to MRI, the trigeminal nerve could not be well visualized. Nowadays, with specific MRI sequences, we can see trigeminal nerve from 3 different angles. MRI can also help us to determine if there is a vascular compression syndrome. Here we have a head CT scan. But head CT scan is not useful in these cases because CT doesn't have a resolution to show us in details the anatomy of the trigeminal nerve. MRI is very important in identifying and showing the anatomy of the trigeminal nerve. In MRI, we have 2 best sequences that can help us. The best sequences are Fiesta sequence on general electronic scanners, or CISS sequence on Siemens scanners. Fiesta means fast imaging employing steady state acquisition, and SICC, constructive interference in steady state. These both sequences gives us high resolution of the anatomy around the trigeminal nerve. Here we have an MRI axial view. This is a Fiesta sequence where we can see a trigeminal nerve on the right and the trigeminal nerve on the left. Here we see a small blood vessel that touches the trigeminal nerve. In the other side, we see the perpendicular, the other blood, the small blood vessel that also touches the trigeminal nerve. This is why specialized sequences are very important. Here we have an MRI coronal view that help us to see the trigeminal nerve. The trigeminal nerve is presented here on the right side and the trigeminal nerve in the left side. Here, the trigeminal nerve is touched by small blood vessel. Here also we can see the compression of the blood vessel to the trigeminal nerve. Here we have an MRI sagittal view where we can also see the trigeminal nerve passing here and the blood vessel touching the trigeminal nerve. MRI vascular compression. MRI is also very important and can help us to determine the number of blood vessels. When I say the number of blood vessels, means that it can be more than one blood vessel that touches the trigeminal nerve. That also can help us to see the type of blood vessel. It can be artery in most cases, but in some cases can be artery versus vein. And the artery pushing nerves also, we have to say that they have better outcomes. In these cases of trigeminal neuralgia, it's also important the size of the blood vessels, because we saw that in the other cases were small blood vessels that touched the trigeminal nerve, but in rare cases there can be enlarged blood arteries that can push the trigeminal nerve. Here we have an MRI scan. We have a single artery touching the trigeminal nerve. In this case, we have two vessels touching the trigeminal nerve. Here is one blood vessel, and the other is this one that is touching and doing compression in the trigeminal nerve. And in this MRI scan, we have an enlarged artery, which causes pressure on the left trigeminal nerve. MRI also can help us to determine the pathology. We said that vascular compression was the main of the cause, but also there can be other causes. The cause of the trigeminal neuralgia can be a malignant tumor, can be a benign tumor, or an autoimmune disease like multiple sclerosis. Trigeminal neuralgia represents a reflection of metastatic tumors or of the tumor lesions themselves at the level of cranial nerves. Tumors are often found in pontocerebellar angle, but also multiple sclerosis
is usual cause of trigeminal neuralgia. Here we have a case with acoustic neuroma. Acoustic neuroma here is a triangular shaped structure. The tumor is pushing on the trigeminal nerve. This causes the pressure and gives the pain to the patient. The tumor was removed chirurgically, took the pressure out of the trigeminal nerve and the patient pain. The other case that we have shown here is cause of trigeminal neuralgia is meningioma. Meningioma here is located in temporal petrous part of temporal lobe. The tumor spreads to the pons and the entire trigeminal nerve. The tumor is stained red and the trigeminal nerve is blue. It is seen that the left side of the nerve is compressed by the meningioma. Patient presented severe face pain, difficulty eating, was losing weight. Tumor was removed chirurgically and the patient had complete resolution. The other case is a patient that leans for pain on the left side of the face. MRI of the brain shows changes on the trigeminal nerve shown in the image with the white arrow. The patient was diagnosed with lymphoma. A blood cell tumor has been treated with chemotherapy and radiation. The pain has been persistent, but has been reduced with the painkillers. The other cause of trigeminal neuralgia is a metastatic tumor. Here we have the patient with a lung tumor. The lung tumor spreads all over the body. Here we can see a trigeminal nerve with a bright spot. That bright spot is a small tumor. The patient had face pain, was treated with radiation called cyberknife that allowed to kill the tumor and alleviate the patient face pain. The other cause of trigeminal neuralgia here is multiple sclerosis. Patient developed multiple sclerosis active plaques right where the trigeminal nerve comes out, and the patient developed trigeminal neuralgia. In this table, we have 4 patients with different ages, with different history of disease. Here we have a woman with a breast cancer, have a male with lip cancer, which was diagnosed 3 years ago. We have another male, 72 years old, with a prostate cancer, and the 35 years old boy with who was diagnosed with a glioblastoma. Symptoms of trigeminal nerve were pain and numbness, or only numbness. Neuropathic lesions, there were involved branches 1, 2, 3 in the first case. In the second and third case were involved branches of third branch of the trigeminal nerve. And the last case were involved second and the third branch of the trigeminal nerve. MRI shows us at the first case petrocell infiltration and the lip cancer, and patient with prostate cancer was MRI without alteration, and the glioblastoma is in MRI shown like intracerebral tumor. Here is another table with diagnostic lesions, which we mentioned them before. Time of diagnosis was 7 months, 1 year, 3 years, 6 months again. The patients were treated with medications, and disease progression was improved of pain, was a severity of disease. There were the case with prostate cancer was without improvement, and the case the patient with the glioblastoma was a severity of disease. Trigeminal neuralgia most often involves the middle branch and lower branch of the trigeminal nerve. The pain is felt in ear, eyes, lips, nose, cheeks, teeth. Concept of vascular compression. There is a large variation in anatomy from one patient to another. It is common for blood vessels and nerves to be touching one another inside the skull. Majority of time, the touching of nerve and blood vessels does not cause any problems. What is the usual therapeutic scheme? Trigeminal neuralgia is treated first medication, then radiological intervention, and finally is operation. Here we have to talk something about neuroradiology treatment. The treatment for partial pain reduction is called glycerol rhizotomy, which is performed in the University Clinical Center Mother Teresa in Tirana, Albania.
This procedure is performed by inserting a needle into the cheek from the side of the pain. Needle positioning is guided through digital fluoroscopy into the oval foramen. The trigeminal nerve root is located behind this hole. Immediately after positioning, 0.04 cc glycerol is injected. This substance has the property of destroying the nerve fibers of the trigeminal nerve, especially those that are responsible for pain. This happens between 45 to 60 minutes. What are the complications of this neuroradiological procedure? The consequences and the complications are different. We have persistent numbness of the face. Some patients may have loss of the vision of the treated part. Then we can have infections. Then we can have hemorrhage from damage to the vascular structures near the nerve. Conclusion. It's that the MRI imaging is critical in workup of patient with trigeminal neuralgia. MRI rules out tumors and multiple sclerosis, determine if there is a blood vessel touching the nerve. Also, MRI can help us to determine number and size of blood vessels. And finally, Fiesta and CISS sequences are also critical. Thank you.
Yes, this was the presentation from Dr. Edono Sopaji from Albania, from University of Medicine, from topic MRI diagnosis in paraneoplastic trigeminal neuropathy and rehabilitation. If you have any questions regarding this topic, just you can raise your hand and you can ask the questions. Yes. Thank you very much, madam, for joining this event as a speaker for this conference. Thanks for sharing your tips with us. Also, on behalf of organizing committee members of 2021, we want to thank you for excellent presentation. Looking forward to meet you next time. Actually, we are 30 minutes ahead of actual program. So meanwhile, just we will take 10 minutes break and we will rejoin the event and start our conference presentation. So just we'll take 10 minutes break. Yes, madam. We are going to start the program again after 10 minutes break. If you go to today's leftover speakers, that will be Dr. Justin Benoit, Dr. Sheila Rone from USA, Dr. Sheila Tilin from USA, Dr. Angela Sile. We do have more 4 more talks for today's session to end of this session. Yes. Now, yes. Just be on. Now we asked Dr. Justin Benoit from University of Sherbrooke from Canada. The topic will be rethinking the rating of the movement competency from screen. So we ask you, madam, to start your PPT by sharing your screen.
Is it working?
Yes, madam.
Okay, great. So hello everyone. I'm currently in Canada, so it's 6 in the morning here, but still, I'm very glad to be here today. So my name is Justine Benapio, and I'm a physical therapist and a doctorate student. I'm working with Nathalie Caudreau and Mélanie Morin. And I'm currently working on dancers. So, and I'm presenting today the project that is associated to rethinking the rating of the movement competency screen, which is a smaller project from a bigger one. So that's it. So I think you all know, but musculoskeletal disorders are a major issue among athletes, and dancers are no exception. They are among the most injured athletes, 86% of them sustaining an injury in a single season. It's a sport that's demanding precise coordinated movements and necessitating great strength and power, which could explain the high prevalence of injuries. Dancers' injuries pose a significant threat to their physical and mental health, as well as their career. These injuries and pain episodes occur mainly to the lower limb and to the lower back. And also these injuries happen mainly out of overuse. So I'm going to use the term musculoskeletal disorders, which will regroup injuries and pain for this presentation. So there is a little known on injury risk factors, despite the high prevalence of injuries in dancers. And it is little compared to other athletes because, for example, in hockeyers or footballers, there is a lot of research in that, and dancers, not so much. So there's little known on injury risk factors. But the activation of lumbopelvic stabilizers, lower limb strength, and movement competency have all been identified as potential risk factors among dancers and other athletes of musculoskeletal disorders. So, in order to maintain great functional movement competency, we have multiple muscles in the lumbopelvic area that can help. So in this study, we focused mainly on the transversus abdominis, which is the deepest muscle in the abdominal wall. So if we take a transversal cut, you can see the rectus abdominis. And then over on this side, you can see the external oblique, which is really the most superficial layer. And then you have the internal oblique, and then under that, the transversus abdominis. So it's really the deepest layer. It's really the one near the organs. And in the red square, you can see the layers here, and that's what we're going to see on the echographic image later. We also have hip muscles that can contribute to maintain great movement competency. In fact, the function of the hip muscle groups in itself contribute to alignment of the lower limb, contributing to less compensation while doing fundamental movements like squats or lunges. In recent years, there has been a surge in the interest of evaluating athletes in their globality, so as a whole rather than by segments. And there's also a growing interest in the prevention of musculoskeletal disorders in athletes instead of just treating them. And so movement competency was offered as the answer by many authors to this new problematic. So to evaluate athletes as a whole and to prevent injuries. So among the most popular movement competency screen that were offered, there's the functional movement screen, the FMS, which you probably know because it's quite popular and it was created in 2006. And there's a movement competency screen, which is the MCS. It was created in 2012 and is a little less popular because it's newer, but still it exists and it is quite interesting. The movement competency screen was developed for athletes and has the interesting characteristic of having different load levels. So during the performance of movements, the different load levels are the ones that are usually used in training programs and rehabilitation programs. And it is currently scored on 3 levels, so on a 3-point system. So what we're going to look at here, on your left, you have the scoring sheet of the MCS. So for each movement, you have a list of primary here and secondary compensations. So primary compensations are the ones that really stand out, the ones that are most important, that should not be there because they're compensations, you know. And then you have the secondary ones that are still important, but a little less than the primary ones. And for each movement, you can do it slowly, a little quicker, or sometimes even while jumping. So I'm going to present the 5 movements of the MCS. So here you have the squat, so the full body squat. You can do it slowly, you can do it a little quicker, as fast as you can actually, and then you can do it while jumping. So the athlete squats, jumps, squats, and you do it between 3 and 10 times. So to evaluate if there is any compensation appearing. You next have the lunge and twist. So as you can see on the scoring sheet, there is a different score for the lunge part and then a different score for the twist part. So you can evaluate really like both movements in one. And then again, you can do it slowly. And then you can do it as fast as you can. And when doing it as fast as you can, you have to alternate sides. And finally, you can do it while jumping. So while jumping is a little maybe counterintuitive. So actually you don't jump doing the lunges. You jump from both feet and go on, sorry, go on one foot and you have to stick the landing. So that's it for the lunge and twist. And then you have the bend and pull. So you really go with your arms up and then down in front of you while maintaining a straight back. And then you pull your hands over to yourself and then you come back. So you can do it slowly, once again, quicker, and you do not do it while jumping. So this one is a little different on that. Next, you have the push-up. The push-up is evaluated, oh, sorry, I forgot to say the bend and pull is evaluated on 2 levels too. So the bend and then the pull. So push-up. The push-up, once again, can be done slowly, a little faster, or while jumping. So while jumping actually is you push yourself off the floor and the hands have to not be in contact with the floor anymore. Once again, you do it a couple of times. And for the last but not least, the single leg squat. So you do a squat on one leg with your leg behind yourself, and you can do it slowly or quicker, not while jumping. So that is it. So for each movement, you have to rate for the primary and the secondary compensations. And you also have to note whether it was, done slowly or quicker or while jumping for the plyometric level. And the more compensations you have, the lesser the score. So for the 5-point system, the current and recommended scoring of the MCS is on 3 points, but I'm just going to explain. So Matthew Kritz described a 5-point system, which is the assisted loading, the body weight loading, external loading, eccentric, and then the plyometric loading. And when you have this 5-point system, I told you, remember, that it's on the 3-point system currently. So what we do is we regroup the 5 points into 3 points. So it's the same, it's just that it's regrouped. So the first one is assisted and body weight loading. The second one is external and eccentric loading. And the third one is the plyometric loading. And because these levels, these 3 levels, the 3-point system focus mainly on the compensations with little regard to difficulty and load level of the movement, it can be problematic. So if the movements were instead evaluated on 5 levels, each level representing the load level of the task, it is hypothesized that the observation of compensations, while taking into account the difficulty of the task, probably the movement competency would be better portrayed. So I'm just going to show you the difference between a 5-point system and a 3-point system because there's nothing like example. So you're going to see the dancer, she's going to do the squat item. So she's going to start by doing it slowly, and then she's going to do it a little faster, and then while jumping. So there you go. Okay, so if we start by the 3-point system, so a full disclosure, the dancer is me, and I'm really not a great squatter. So I took example for the patterns and all that, but it's not really representative of what I was doing. So that's it. So for example, if I was doing it slowly with only secondary compensations like depth and balance, I would have it 2 out of 3. And then if I was doing it a little faster with the same secondary compensations, my score would still be 2 out of 3. So not really the most representative of movement competency, probably. If we take instead the 5-point system, if I was doing it slow with the secondary compensations that was depth and balance, I would have a 3 out of 5. And then for the fast movement, I would have 4 out of 5. So you see that the load level, so at which rate you're doing the movement, is really should be represented in that point system. So the objective of this project was to compare the 5-point versus the 3-point scoring system for the MCS when studying its association with the FMS score, the core muscle activation, and hip muscle strength. There was a total of 118 contemporary and ballet dancers, pre-professional and professional, who participated in the study. So we looked at the activation of the transversus abdominis, the strength of hip muscles, and movement competency. So as you can see, the activation of transversus abdominis was evaluated using an ultrasound device. So this technique has been validated to calculate a recruitment ratio, which is really specific to the transversus abdominis. And the evaluation was done in a standardized supine position with a hollow-in maneuver. So what you can see on the screen is really an echographic image of the external oblique in green, the internal oblique in blue, and then the transversus abdominis in purple, which we cannot see really well because once again, full disclosure, it's me and I do not have the greatest transversus abdominis. So you have really the superficial portion and then the deepest portion. So as we can see, I'm gonna breathe in and then breathe out and then activate my transversus abdominis. And full disclosure, again, I'm not the best at activating only my transversus abdominis, so there's really a compensation from my internal oblique, but that's okay because the equation we use to calculate the recruitment ratio makes it really specific to the transversus abdominis, which is great. Next, we evaluated hip muscle strength. It was measured using a handheld dynamometer and some straps, as seen on the dancer here. So we measured the strength of hip abductors, adductors, flexors, extensors, external and internal rotators. So that was quite the measurements. They were taken 3 times on both the dominant and the non-dominant side. The dominant and non-dominant side was evaluated, was self-evaluated by the dancer. So the dominant side was evaluated as the the most stable leg, the leg they would turn on, the leg they're more comfortable to turn on. And so in between the 3 pushes for each muscle, there was a 30-second break in order to avoid fatigue. So movement competency, of course, was evaluated using the MCS, the movement competency screen, but I was also willing to compare it to the FMS, the functional movement screen. So the functional movement screen has 7 items. It's scored from 0 to 3 with really specific descriptions for each scoring. So it's a little less, how could I put it? It's a little clearer than the MCS, let's say. So you have the body squat also, and then you have the hurdle step where you have to not touch the cord that's here, and then you have the inline lunge. You have the flexibility, which was not a major concern for most dancers that I evaluated. And then you have still flexibility, a little, sometimes it was problematic for some, but not so much. And then you have really the one that has, it's actually, you have to extend the same arm and leg. So it's quite a I don't have the word in English, actually. It's quite a défi. So that's it. And then you have the push-up, that's the same. So you have 3 items that are quite similar: the push-up, the squat, and the inline lunge. To evaluate the 5-point and 3-point system, we started by linear regressions to identify variables that could be linked to the MCS score, either on a 5 or 3-point system. And to compare the point scoring system, hierarchical regressions were used for the 5-point once again, and the 3-point system using the FMS score, the transversus abdominis activation, and hip strength. To avoid multicollinearity issues, only one group of group muscle from the hip was used, the one that was most significant in linear regressions. So as you can see here, for the 5-point system, the linear regressions allowed us to identify multiple variables that could be linked to the MCS total score on a 5-point system. So as you can see with the arrows in green, there was the transversus abdominis activation, hip extensor strength, hip abductor strength, which was the one that was most significantly associated for the hip muscles. And then you have hip external rotator strength that was associated with the 5-point system and the FMS total score. So out of this, we chose the ones that were most associated. So the transversus abdominis activation, hip adductor strength, and FMS total score. So that was used for the hierarchical regression. And what we found is that it could explain significantly 24% of the total MCS score using the 5-point system. Once again, the same steps were done for the linear regression. So on the 3-point system, you can see that there is much less regressions that are significantly associated. So there's the hip internal rotator strength and the FMS total score. Once again, we use the same variables for the hierarchical regression, so we could compare the same thing. So for the 3-point system, the transversus abdominis activation, hip adductor strength, and FMS total score could significantly explain 4.5% of the MCS total score in the 3-point system. So if we compare, the 5-point system was 24% and 3-point system was 4.5%. So what we can see is that the 5-point system was more strongly associated to variables that have been previously identified as important in movement competency. That's transversus abdominis activation, hip strength, and movement competency with the FMS. So these results suggest a higher convergent and criterion validity. If we look at the literature a little bit, in previous findings on the correlation between the MCS total score that was on 3-point and the transversus abdominis activation, hip strength, and FMS, they were interesting, but with the linear regressions we did in our study, we could not reproduce these results. It was found that 24% of the total MCS score using the 5-point system could be explained by the variables, while in the literature, this was about like 10.8% for the 3-point system, and compared to, of course, the 4.5 that we found on our site. So the results of this study have an impact on the scoring of the MCS, and we believe that it will now be more representative of the load level. It could help also to better discriminate which athlete is at risk or not of musculoskeletal disorders, which is pain and injuries. So it confirms that a 5-point system is more representative of essential components of movement competency screen, that is transversus abdominis activation, hip strength and movement competency evaluated with another tool, namely the FMS. So, of course, I can take your questions now, but if you have any more questions or comments, you can email me or call. I will get back to you as soon as I can. So thank you so much.
Yes, ma'am. This was the presentation from Dr. Any questions to Dr. Justin Benoit? Any questions? Just if you have any questions, ask me for you. Even after the completion of the conference. Any questions? I think there is no questions, madam.
Thank you so much.
Yes. Yeah. Thank you so much, madam, for participating in this event. On behalf of organizing committee members of Virtual Physiotherapy Congress 2021, we want to thank you for this presentation. Looking forward to meet again next time. Yes. You will be getting the electronic booklet as well as soft copy of certificate after the completion of the conference within 3 to 4 working days of the conference. Working days. Yes. Next, we ask Dr. Sheila Tillin, President, Vestibular Training Service and Master Coach from USA. The topic will be Vestibular, Take Your Brain for Spain. Yes, madam, go ahead by sharing your slide.
Good morning. Thank you so much for your time. I'm so grateful to be here. I'm not a doctor, though, just to make that very clear. I'm not a doctor, but I am a master coach, and I have an amazing presentation for you. So I appreciate everyone's time.
Please apologize, madam. Yeah.
All right, I'll just get going right away here. Good morning. So, hi, good morning. I'm Sheila Thielen. I'm the president of Vestibular Training Services, and I have I do a whole thing on the fact that I'm not a doctor, but I am a master figure skating coach. And so for 30 years, I've been a vestibular genius, and I didn't know it. Turning, balance, turning. I worked with about 500,000 children worldwide. So like I really started doing amazing work with my harness systems that I'll show here in a moment. And this was just standard work really within the figure skating and the sports industry. Harnesses are a very, very big part of promoting safety and balance for the children. So with that, I talk about being a vestibular genius, where at the same time, and not really understanding that, where at the same time, doctors and PTs and OTs and 27,000 articles on PubMed all about vestibular. So really what this project is that I'm presenting today is bringing the two projects together, specifically the sports of figure skating, rotation and harness, and balance of vestibular to the rest of the industries all coming together. Really, this work that I've been doing has been over 30 years. So this isn't new technology in my mind, but it truly is for the rest of the industry. It really is innovation. So I'm going to share my screen. Well, welcome to my screen. It's always a little messy. Okay, here we go. So here we go. Let me drop out all these other nice little pictures here. Oh, goodness. Here we go. Here we go. So the first video I'd like to work with today is some of my stunning videos. This is one of my famous videos that has gotten the attention of thousands of people. And with this is one of my top athletes. And this is really what I'm used to working with. This is a standard athlete that I will work with. So not only are we talking about vestibular imbalance, but we're also talking about cognitive of the vestibular system. So you'll see she starts out on the platter and she accelerates. And oh my goodness, this is the project. So it's really amazing vestibular input, but on top of it, it's also got additional values of axis, balance, proprioception. She's got a midline cross, which we think is imperative. And what it does for her brain is outstanding. Listen to her talk here in a moment. Here we go. An athlete, really impressive. Okay, coming down. And then of course, the most amazing part to the whole story. Okay, how dizzy are you?
I'm not dizzy.
She's not dizzy. Not dizzy. No. Thanks. Have a great day from Vestibular Training Services. I always laugh. I've had so many people be like, "Does she even have a vestibular system?" You know, yeah. This is what the project really is, and of course, that's the advanced end. You would assume that would be my top video in my LinkedIn and in our YouTube and everything else, and in reality, this is my #1 video. Which is my beloved neighbor. So with it, she's 65 years old and she has really, really bad balance issues, horrible balance issues. So for her, she's not going to take flight like you saw the athlete. She's just going to stand on the platter. And now the harness system has turned into basically a safety device. So with that, you can see that she's just going to make one turn. And this is my #1 video, which always kind of cracks me up, because when you see the difference of what I'm used to working with, it really is, it's impressive to see the changes in people's balance based on really, in my mind, not much energy on our part. So look at, and she has improved her balance. In general, everyone does 3 sets with me. So with that, I'm going to show a series of balance board information of what we've calculated. We use a BioTrax Biomed tracking system. So it's really easy for us to move this around here a little bit more. So with that, so the starting balance on a 75-year-old woman that I'm going to show here next starts out with, she has 22.79 movement in her feet. We're doing this based on a 1-foot balance process. So scoring on 1-foot balance, and she's got 7.14 in sway. So with that, you know, she's got a lot of movement there. So this is her initial balance. And then here is what we do with her. We do this a total of, again, 3 sets. So with that, so for 3 sets, she's just going to do these really, truly gentle turns and vestibular training just right here, nice and easy. So she's 75 and has not bad balance, but not good balance either. You know, so she's kind of just starting there. And it's gentle. So the harness, the one issue though, I do have to say with the harness is it is very tight to the body. So if your patient is truly frail, this is not a good harness. This is not a good project for them at all, because they really do need to be tight to that body harness. And that's it. That's all she did. In the end, she's going to do this video basically 3 times. It's kind of from like the weightlifting years of 3 sets. And she does it 3 times. So she does a total when we're all done of 13 turns. So in a matter of 13 turns, we retest her again, and her balance has improved dramatically. So in comparison, so you can see she started out at 22.79 and she drops down to 9.81. So an excellent score. She also drops from that sway of 7.14 down to 0.18. So we're stunned. We think this is fantastic. And look at the progression. It was very easy, and easy on the client and easy on you. This wasn't a lot of work. So increasing that vestibular really helped her balance. We're excited to see these kinds of numbers. So let me show a couple more sequences here, where I'm just going to not do too many here. So opening balance on a post-concussion client. So this one is post-concussion, and I'm moving all around here on my screen. Here we go. So with post-concussion, it really, it's a trickier group of people that you really have to be careful with. So with that, so for post-concussion, an excellent score, really, this is a 2-foot balance. And we've also got, so let me show the video. Actually, and here's his 1-foot balance before we get started. So the 1-foot balance is excellent also. You know, it really is some really good scores before I've even started. So with that, here's the video. Post-concussion, approximately 7 years. So it was a bad concussion though. So 7 years from a car accident. So same thing, nothing hard, nothing fast, not like my initial videos of some of my athletes, but you can see that this is, it's not hard. It's easy. I can control everything with my foot. So I've already set the speed. I just step on the foot pedal, and now the harness is there just for extra security and stability to then allow them to feel safe. But if he did fall off, I can catch him. It does have a triple pulley system. So even as someone's super, super short, I can control this easily, even on much larger people. And that's it. That's it. I think he had a total of 7 or 8 turns. Nothing hard. Okay. So looking back, let's look at his scores here. I'm just going to drop out of some of these here. So here's his initial 2-foot balance score. Then he did that video 3 times. And here are the new scores. So here's our initial scores. He did the spinner and harness 3 times, a total of approximately 5 minutes. And here's his new scores. So you can see from the sway area, we're going to drop from the 0.15, which is an excellent score, all the way down to a flat 0, which I find so impressive. He's going to drop his movement from 7.23, really in his feet in the process and the displacement, down to 1.99. which is just exceptional. You'll notice too, you can even see it in the movement and the lines, but you can really see that he moves from really the right side and a little outside, even in the balance, that was excellent, to literally almost dead center, which there's your vestibular training for you right there. So I'm going to quick look at his 1-foot scores also. So on his 1-foot score, same thing, exceptional balance. Did that video 3 times, 5 minutes later, retested again, and once again improved his scores. He had a little bit more centered balance on the first one, but he still had 8.50 in movement, and with a sway of 0.07, still exceptional scores. I'm always like, I don't know if I can beat that. And then I'm always fascinated when, after doing vestibular training, we do. So with the sway, drops from 0 to 0.2, and of course his movement drops to 5.76. So it's amazing to see the difference in the application of vestibular and balance to even an aging population. I'm going to hop around just a little bit more, just to show a couple more quick videos, because I do have some really fun ones. This one is one of my athletes that we added in a Hiko stick. So the Hiko stick has the 3 different colors on it. And at the end of the vestibular training, I'm going to throw it at her and see if she can catch it. So not only does she have the vestibular, but immediately into a spatial and also a decision-making process. So here's one of my athletes. And so you can see how fast she's going to be in the rotation. And once again, this is an advanced athlete, but with that, so she can take the spinner and she can take the flight portion. So now we use the harness for flight. It's easy to run. Once again, with that triple pulley, I'm not lifting much of her weight, but she's got the axis the midline cross, the vestibular, the proprioception of tracking her feet. And really, it's fun. So we'll even add in there's some dopamine, a nice dopamine load that she enjoys. Everyone enjoys doing this. So she does this for 3 sets. Normally, then I call a color, and she's got to catch the color. I'm always fascinated when they can do that. And she caught the blue. I called blue, and she caught the blue. So with that, as we start talking about spatial, brings me to really one of my final videos. I'm not going to take up too much of your time here today, but one of my final videos is actually with the U.S. military. My next one is a former athlete of mine that is, she flies helicopters. So she's a helicopter pilot for the U.S. Army and a former athlete with me, and has had so much vestibular training, So here we go.
So being a figure skater, it completely changed my life with aviation. The training I received through years of skating made me basically immune to spatial disorientation. They've put me through every test, every Blarney chair, every spinny apparatus, the spatial disorientation pods, and I cannot get disoriented. I always know where my body is. I always have a sense of where the ground is, how to right myself, and also the mental clarity on how to stay calm. And that all came through skating. It all came through the years of spinning and coming out of a certain position, spinning with my head in different ways. And it's literally going to save my life as an Army aviator. And I feel like vestibular training could save the lives of all aviators, because you can train spatial disorientation out of you. You can learn to not get spatially disorientated. It is a learned, practiced skill that is possible.
Thanks so much. Have a great day.
Thank you.
Service.
Thank you.
That's Megan. Isn't she amazing? She's absolutely amazing. So with this, as I think, I really want to present the concept of vestibular training and how it can really help, obviously, in the whole balance realm. Our project is very easy to do. I have 12-year-olds that can run the gear. It's not taxing, and really I can easily slide through 100 people a day. This can easily be run by a para. This doesn't take any advanced skill. And obviously all of our gear does come with a full training package for your staff, either virtual or actually even in person. It's more fun to see the gear even in person. So I invite you to come try out my gear with me in person. I am located in Minneapolis, Minnesota, but I do have gear worldwide, because really realize this is a 30-year-old company. We have gear worldwide, and we speak at conferences worldwide. So with that, we've been doing this a long time. So I invite any of your questions, and I truly appreciate everyone's time in watching all of this, because really what we're doing is innovation that is really actually old in the world of figure skating. So any questions anyone has?
Yes. Any questions? Just if you have any questions, you can text in chat box. Will be asking behalf of you, even after the completion of the conference. Any questions? Yes, ma'am. I think there is. Yes, you can.
Trying to see it here in the chat here. Hold on. Oh, thank you. Thank you so much. That's very kind of you. I'm truly grateful for everyone's time. This really does, move, and it's got a lot of activity to it. And it is pretty easy for people to learn. There's obviously different degrees and skill level, as you can see. But with this, it really is designed to be 2 to 3 times a week and 5 minutes. Easily installed in a home. easily installed in a therapy situation. You know, it hooks just right to an eye bolt and you're ready to go. So, do you have any videos of children? Absolutely. Let me go back and share my screen here real quick. I have some amazing videos of children. And this also goes back to cognitive. Obviously this is balance-based, but I'm gonna just quick show this little one. This one we're using just the harness system. So she's 5 years old in this video, and she's actually singing at the beginning. I just muted her here, but she's singing. You can see that the harness goes on very easily. It's just Velcro, and it's really, but it is very tight to the body. And the children don't seem to be bothered by that. So I can hoist her up. She's very little with the triple pulley. I can just control it with one hand for her. But notice she's got the midline cross. There's actually the Moro reflex that kind of helps rebalance it all. So she uses Moro quite a bit to rebalance. And then with that, she's got the midline cross, the axis, the balance, the proprioception. She enjoys it. You can see that. She really likes it. And it's impressive to see her improvements. So actually, as I quick show this video, I have a series of 3 videos on her over a 14-month period. And she's done amazing work, not just balance-wise for this, but also cognitive. Her reading skills have improved dramatically, which we're really proud of seeing. You know, like her, it's a true change. She's showing you her nystagmus here. That she doesn't get as much dizzy anymore. But just to follow her sequence real quick, so that's her video, and then 14 months later, this is her skill level that's increased dramatically. So here she is 14 months later, same little girl. We did have multiple COVID shutdowns, so she did have several breaks in training, but look at how much she's improved. So much improvement, you know, so like it's really fascinating to see how much she's improved. And her, like I said, her reading skills have it's major improvements. So according to the family too, according to her mother, she has 60% less emotional breakdowns a day, which according to the family has improved their lives by 100%. So 50-60% less breakdowns. Her diagnosis was on the spectrum, and with some autism in there. But she is a spectrum kid, and she's improved dramatically. So we actually have several research projects starting worldwide, specifically to children with autism and our product, which we're very excited about. We have 2 major projects starting worldwide that are involving approximately 8 universities and children's centers. So we actually even have a PhD on staff, just coordinating all of our research with our team too. So how exciting to see that apply to the children in the autism group. But it is fun to see who's using our work. We actually have multiple large companies that I can't discuss, but we'll be discussing in the future months coming up. But really, I think when you take a really great physical therapy program and you add vestibular to it, it really, really improves. I think when you take a really good EMDR, psychology type program, add vestibular to it, it really improves that project also. But I think when you look at education and reading programs, especially for children, you add vestibular to it, that's where we're seeing really exciting work and numbers. And really, we want to change the world and not look crazy or sound crazy in saying that. So I invite all of you to please connect with me. You've asked a couple of great questions. I really appreciate that. And if you have any questions, please feel free to contact me through the conference, and anything I can do to help you or your team. I do a ton of Zoom meetings. So please join me, and I look forward to more projects with you in the future. Thank you so much.
Yes. Yes. Thank you so much, madam. This was a nice presentation from you. You have shown different videos regarding your vestibular training. and we really appreciate everything that you have done. It was a great video. Also, on behalf of organizing committee members of Virtual Physiotherapy Congress 2021, we want to thank you for your presentation. Looking forward to meet again next time. So, if possible, in 2022, if everything goes well, we ask you to join as a workshop presentation. You can show all these videos in a workshop. So, you will be the allotted for 45 to 1 hours time allotted for your workshop. If possible, you can join this event. Hope everything goes well in 2022. Yes, this was the vestibular training service.com. So next we have 2 more talks left for this conference, that is talks left for the conference, that is Dr. Angela Sele as well as Dr. Sheila Rone from Koenig LLC USA. So they required more 20 minutes for preparing their talk. So we will go with another talk, that is Dr. Edonos Sapoji from Radio Department from University of Medicine from Albania. The topic will be MRI diagnosis of disc herniation and rehabilitation. We asked Dr. Helen Milson, the PH Sports Physio.
Hello.
Yes, madam. Yes, go ahead by sharing your PPT, or you can give a general topic that you are having. You can give. You can go with a general topic.
You want me to get my PowerPoint?
Yes.
Okay, let me just see where I can share it. Where's the share thing?
Yes, you can find from the bottom of the screen with the share screen with the green color.
Well, I've got it. I'm trying to get it onto my. Here, let me just have a look.
If you are unable to share, you can send me immediately. I can play from here.
Yeah, I'm trying to find it on my desktop. I've got it on my desktop somewhere here.
Okay, take your own time.
Thank you, let's have a look. Desktop. Nope. Why won't it take me to my desktop? That's interesting. Sorry, I can't see it coming out. List of my files, Microsoft Dropbox, no. Should I just send it to you?
Yes, you can share.
It's not coming. It's not. Yeah, but it's not coming onto my share. It's not coming onto my. I need it on my desktop. It's not coming to my desktop. Let's have a look.
I think you are. Yes, it's going to.
Okay, let's see this one.
Yes.
This might do it. This might do it. Can you see that?
Yes. Just open it.
Can you see that?
Not yet.
Is that okay?
Just open your PPT with full screen. We are not just we can find your PPT only in the folder Just open it with full.
Sorry, can you see this now?
Yes, yes.
We only see your screen, your screen, full screen, desktop.
Okay, so should I start now? And have I got 25 minutes?
Please.
Have I got 25 minutes?
Yes, yes.
Okay, so you can see the screen clearly, can you?
No, madam. Just listen to me. Just you
Can
have.
you see?
Just you have
Can you-
opened. Just you have opened your file, your folder on your.
It's open. It's open in front of me. Can you not see it?
No, not it.
You can't see it. It says it's sharing. It says it's sharing.
Just go ahead. Yes, you can proceed.
So I just want to know, can you see my screen?
Not yet.
Is that yes? Can you see my screen?
Your desktop is appear to us, but you
I'm
didn't
sorry, I
start
just need to know
anything.
if you... Okay, I just need to know if you can see my screen. Is that yes?
Yes.
Yes.
Okay, that's fine. Okay, so I'm going to be talking for a very short time on groin and hip complexities. Is prevention viable? Normally this talk takes about minimum hour and a half. So I'm afraid this is just the tip of the iceberg, but just to let you know how complex it is. I work with the Premier League football in England and with Paris Saint-Germain and Bayer Leverkusen. And it was the Premier League doctors who kind of pushed me into doing my PhD, which I've just finished now, on groin and hip complexities. Is prevention viable? So I've just plucked out a couple of the slides to give you a taste of it, but it's just a taste, I'm afraid. So if you look at this picture carefully, just look at the groin. The groin and hip has been so badly kind of studied until very recently, because look at the pressure on the groin and hip. And everything's about core stability, which is very important. But what about what goes on around there? So that's really, really important.
Excuse me, madam.
Okay, so yeah?
We are unable to see your PPT on the screen. You are not sharing your PowerPoint presentation.
Well, it says sharing, and it says it's sharing.
Actually,
that's why I asked.
Actually, you are presenting from other system, not you are utilizing two systems for presenting. You can share.
May I assist?
It actually says it's sharing.
May I assist you, ma'am?
Yes, sir. Go ahead,
Dr. Milson.
Yes, go ahead.
I asked you when I started, can you see the screen or not?
We are seeing your presentation, but it's the folder on your desktop. So my advice is, just stop sharing for now.
Okay.
At the top.
Yeah.
Yes. And then now you can share again. Go to the Zoom platform and then go share on the green button at the bottom.
I've got that. Shares, yeah, I've got that.
And then you're going to select your screen that has the PowerPoint.
Can you see that?
There it is. Thank you. Yes.
Yes.
And then you can use the PowerPoint presentation mode so that it can be bigger.
Yes, it's
Thanks,
fine.
Dr. Middleton.
Okay, so now all I want to know is, can you see it now?
Yes, sir.
I don't know why I did exactly the same just now. Exactly the same. Okay, let's get a move on. Sorry, but I won't go into what I said just now. But basically, look at the complexities of the groin and hip. And the bottom line actually is that I did this for my PhD, and I had over 2,000 studies but I was allowed, being a professional PhD, I could marry my experience. I went to all the conferences around Europe, as well as the 2000 studies. And what I've come out at the bottom line is what you can take home from this today is going to be, yes, prevention, prevention, prevention. I think we've totally neglected it. So let's move on. There are many, many studies. And look, you can see I've got the 2021, the very latest studies. Now, all of a sudden, the groin and hip is big, big, big. So basically, it's fantastic. But Ryman is one of the top guys in the world. And as he says, there is no agreement on how to classify, define, or diagnose hip-related pain. It's a common cause of hip and groin pain in young and middle-aged active adults. I can tell you, working for 13 years with Premier League and with all the other elite sport, not just Premier League, it's very, very common. And they still have got no agreement, which is why I want to share with you that we as physios, fitness people, we can prevent and we can rehabilitate without all that intricate knowledge. So I'm going to move on from that. With what about this diagnosis? There's a coexistence of multiple pathologies, a lack of agreement of diagnostic criteria. There's huge discrepancy there. Non-specific nature of the signs and symptoms. Lack of specific clinical tests, absolutely. There's minimal evidence for the efficacy of conservative treatment, and there's very little evidence for prevention. But that's why I even do day workshops to show you why I promise you we can prevent. I have no doubt whatsoever. So I'm just very briefly going to go into this. I'm not so bothered about differential diagnosis. It's very complex. I'm not going to go into the specific tests, the radiology, the surgery. We haven't got time for that. My absolute criteria is anatomy versus functional anatomy, functional movement assessment, and that leads to rehabilitation and prevention. So that number 2 and number 3 to me are absolutely critical. So if you don't know your anatomy and your functional anatomy, then you won't get them better. So we'll go, just the one I've plucked out there is the Doha Agreement in 2015. That made a huge difference to the management of groin and hips. If you haven't got the study, it's important you get it. It's absolutely accepted all over the world, and it divides everything into adductor-related groin pain, iliopsoas-related pain, inguinal-related, pubic-related, hip joint, and other causes. And that is a basis now which has made a huge difference. And a new study has just come out to say, is it still any good? And the answer is definitely yes. That's one way of analyzing groin and hip pain. The take-home message in terms of differential diagnosis is the findings of multiple abnormal clinical entities tempt one to speculate that one clinical entity likely precedes others. So I've got, as I said, I've got over 2,000 studies, but what I want to say is that when they come in, especially when they've got chronic groin hip pain, you probably find there's overlapping conditions. So there's no gold standard for diagnostic definition. And that's why the doctors have huge problems, because unless they get a definitive diagnosis to send to a specific surgeon who deals with that particular pathology, they have a problem. And we must know, and now as a physio, I'm getting so many patients with groin and hip problems, and I haven't always got the diagnosis. I go through everything, but I haven't always got the diagnosis. It doesn't matter. I promise you, I can rehabilitate them, and I definitely could prevent. So what do you do if you haven't got a definitive diagnosis? What is conservative managed prevention? What is the best practice? A thorough understanding of structural and functional anatomy. We're going to do that. Know the risk factors, screening. Understand the role the hip and groin plays in a combination of movement patterns and dysfunctions. That is the biomechanics. You have to know the biomechanics, not just of the player, but the particular sport and the position that they do it. I play a lot of sport, and even like now I'm kayaking, and that because I used to treat those guys. I went out there, I kayaked to learn about it. With rugby, I've done Springbok rugby, South African rugby. I sat down and watched every single functional movement. So you've got to understand it. You don't have to play it, but you've got to understand it. Identify and correct all the abnormalities and maladaptation. The tests must be functional and specific, not just the specific tests. All that leads to a good rehabilitation and definitely prevention. So what's the best practice? Anatomy. I'm going to talk about anatomy. In fact, look where his leg is. Look how hard the iliopsoas is working there. What strengthening is there preventatively or rehabilitation in that line? And that's a soccer player. What about the cricket bowler with their leg up like that? We haven't been taking notice of that for a long, long time. So anatomy is what I'm really going to tell you. And that's functional anatomy versus, functional anatomy versus a structural anatomy. So look at those pictures. Have a good look at the pictures. I'm not going to talk in detail because there isn't time, but look at the pressure on the groin in all those different areas. And by the way, goalkeeper ice hockey on the right-hand side there is definitely the most hip problems of all the different sports. But look at all the different ones. Do we take note of that? We've never done that. Now it's individual. Look at all those things. So understanding the structural anatomy is critical. So there's from Bruckner and Kahn's excellent, I love their books, and they're the best in the world. But look at this now. This is beautifully done, showing you all the different, the rectus femoris, the canal, everything's just perfect. Is that what it looks like? Is that what the symphysis pubis and the attachments look like? The answer is no. Look at that. That's anatomy in reality. Look at pectineus, rectus abdominis, adductor longus, and brevis. Look at the interconnectedness over the pubic symphysis. And how we, again, I'm going to say it again, we do core stability and we strengthen our abdominals. But look at the pressure going through, which I'm going to show you now. Look at the adductor muscles. Adductor muscles are, I'm going to be talking about them a lot, but the adductor muscles are stabilizers and prime movers. So the one on the right, his left leg, is a stabilizer. The right one is mover. Have we strengthened it in that range of motion? Look at the pressure around the symphysis pubis. You've got to strengthen all those. So we'll move on to that. And in 2021, one of the recent, there are lots and lots of studies, but the recent one says long-standing adductor-related groin pain is widely common problem for athletes in many sports activities, which drastically reduces player activity and performance. We so can prevent that. I have found, even looking after the Super 14 rugby team here for 5 years, the adductors were so weak. We never strengthened them, and certainly not in different ranges. So I worked on that, and they did extremely well. Another Mosler is also excellent. Adductor-related groin pain comprises 2/3 of all groin injuries. Adductor longus is the biggest one, 90% of the cases. And we can so strengthen that. And I've really seen the difference in my practical work. So look at the biomechanics. Look at rectus abdominis pulling up, adductors pulling down. Can you see the torsion around the pubic bone there, about the pubic joint? There's tremendous torsion, and we've only worried about the upper part, not the lower part. And at this 2021 to date, the lack of rehabilitation guidelines and return to play criteria makes this clinical entity difficult to manage. I don't think it's difficult. I don't have to go in the studies. As I say, mine was a professional PhD. I know practically that if you strengthen the adductors, you will not have adductor problems in the same way. You might get definitely the odd traumatic one when it's quite dramatic or sudden movement, but generally you can make it better in spite of what the studies say. And then the muscles that I'm plucking out, and I'll do it a few times, gluteus medius. not only does it have an effect on the whole hip groin, but I've found that I'm treating all the ACL, the young children with ACL injuries here in the hospital, and they are so weak in their gluteus medius. And if your gluteus medius is weak, you have huge pressure on the knee. So not only groin and hip, but you can help your whole lower extremity. Okay, so you get gluteus medius, there are 3 parts. There's no time to go through each section, but they all have different functions. And it's really important to work on them separately. And tensor fascia lata is an abductor. That is the abductor. The others are stabilizers. The gluteus medius and gluteus minimus are stabilizers of hip joint, which when you think about in the sports world is critical. In fact, just walking, and even when you're aging, it's so important. Gluteus maximus, also, people sit in front of the computer all day and they stretch their gluteus maximus structurally. And gluteus maximus doesn't work in jogging, doesn't work in anything except climbing and sprinting. So if you have a look at the gorillas, baboons with their big bums, that's because they've been climbing up. And we don't do it. So we need to strengthen the gluteus max. I'll show you how. And it's multitasking. I'm not going to go into detail on all the different tasks, but normally I go into all the details about the upper glute med and the lower glute max and the lower glute max, because they have different functions. It's multitasking. And bear that in mind. We have to strengthen it because we're not strengthening it. We're stretching it, we're lengthening it, we're weakening it. So other areas, which I'm not going to go into now, is iliopsoas. They do studies critically important and what's required in that particular sport. And the symphysis pubis, we do ankle joints, knee joints, shoulder joints. This is a critical joint with amazing load going through it. We don't realize it's a joint like any other joint. So every muscle attached to that must be strengthened. And I'm now going to just pluck out things that are really important. Posture. Whenever we look at posture, we see anterior tilt, posterior tilt, and the effect it has on the back. However, when you do anterior or posterior tilt, you have a huge effect on the hip joint, which we haven't taken no notice about. And a 10-degree increase in anterior pelvic tilt has been shown in the study. You get 6 to 9 degrees of loss of hip internal rotation and 10-degree loss of hip flexion. That has such implications. So now sometimes people even have operations. Just check their posture, check the pelvic tilt. Very important. The other thing is the so-called FAI. It's not FAI. There's so many studies. I've been to the conferences in England on this, and the big one was in 2016, the Warwick conference. And what you've got to know is this, they used to call it FAI, femoroacetabular impingement. In the general population, is 15%. In males, it's as high as 75%. So what is FAI? It's no longer called FAI. What it is loading the hip joint. It hasn't evolved like other joints in the body. So what you do get there is a morphology. You get growth there, where you get the pincer and the cam. Particularly in football, 75% of the players have cam morphology, which is the body's reaction to the loads that you're putting on it in different ranges. And it's quite normal. And it's particularly because when they still have their growth points, the young people, that's when it goes. And that's called a hip morphology. And it's only called FAIS, femoroacetabular impingement syndrome, when there is pain. And you don't often get pain. The problem is nobody knows if this leads to osteoarthritis. Does that lead then to labral tear and other tears and leading to arthritis, which is why now there are many, many studies. But certainly if you see this on the radiological imaging, it doesn't mean it's a problem at all. And it can be just like a red herring put over there. So what is the problem? Because it might lead to OA. And what about children? We should now seriously start to consider activity modification. So you have to decrease the workload when the children are still growing. prevention. And Igor Tuck, one of the top guys in the world, in 2015, he came out, prevention of the formation of the CAM deformity, or morphology is a better word, might be possible for adjusting the type, duration,
Yes, madam.
Hello?
Hello. Yes, it disappeared, madam. Can you start sharing from your side again?
Can you see the screen?
It disappeared.
Yeah, I saw that. It suddenly disappeared. Oh, my word. Okay. Okay, are we back on? Cool. Okay. So the take-home message for anatomy is, don't look at structural anatomy and think you know it all. That's what you learn as undergraduates. Look at the functional anatomy. That's really, if you don't understand it, you have to before you even consider yourself a physio, especially, well, I'm dealing with sports. So rehab prevention, what's the best practice? Know the risk factors, the second thing. Number one is the anatomy. Number two, the risk factors, the biomechanics. Address all the biomechanical abnormalities. I had somebody yesterday with very bad hip pain for probably about 5 months, and it was a tennis player. And I didn't know what the diagnosis was specifically. I had a provisional diagnosis. I looked at all the biomechanical abnormalities. Treating a single pathological anatomical entities is limited. So you think, it's the adductor only. No chance. Look at all the biomechanics and correct them. So it takes long. It's not half an hour, that's for sure. And load. Be careful about the load transfer. So you've got to strengthen anything that's malfunctioning so the load transfer is good. The other thing I want to bring up, screening tests, because Raul Barr is one of the top guys in the world. He's fantastic. I've got huge respect for him. But in 2016, he came out, why screening tests to predict injury do not work and probably never will. He says it detects current injury problems, but can't detect future injury risk. Well, I've got profound respect for him, but I totally disagree. I've got lots of studies that now show you that that's not correct. But more importantly, I want to show you that I've used screening in all my national teams, provincial teams, and it makes a huge difference. So screening, yes, does help, unquestionably. And in particular in prevention. So if you screen pre-season, you definitely will prevent. There's no question about it. Don't worry about any studies, although more studies are coming out now to show it, particularly adductors, funny enough. So assessment, I'm not going to go in assessment again, but what I want to show you, don't forget functional tests. I'm not going to go into them now, no time, but look at this wicket keeper. He's a national wicket keeper. He's in this position for how long, for how many years? The hip can get totally messed up. I know squash players and wicket keepers who've had total hip transplants when they are older. So be very careful. How strong was he in that position? Look at the squash player. And look at the cricket bowler. 4.6 to 6.2 times body weight on landing. Do you know how much pressure that is on the symphysis pubis? Huge pressures. So you do tests accordingly, but there's no time for that. I just put one test there. And normally when I give the test with people in front of me, I make them stand up in that position. Do you know how people cannot hold their leg in that position? Even top footballers, rugby players, they can't hold it there in flexion adduction, external rotation, which is a PNF pattern, by the way. And that's a huge test to see, are there weak hip flexors, weak adductors, and so on. So you do functional tests. I'm not showing you all of them, but I've just got that one. Specific tests, again, no time to go through them. There are more and more studies coming out about particular tests, which is a good thing. So these are some of the tests, and I could, as I say, I normally go through each one and say which one I find definitely works for me and which ones don't. But you still do them all. You have to still do them all. The squeeze tests are the most popular, used in all my elite sport that I work with. And it's very, very good. Of course, it's not very specific to adductor longus or adductor brevis, but all the clubs use it. And mostly they use the one with the bent knee one, as in there. And it's best to do it after training without a doubt. What is good is when I was overseas, one of the football clubs told me to come and have a look. And now they've actually got this groin bar, which is very functional and very specific, which is good. But if you haven't got money, it doesn't matter. You just do your normal squeeze test, or you do this one, Thorberg's one from 2016, which is the it's very good. It tells you exactly what's going on, which is you don't need the fancy groin bar. So what's the solution? I didn't go into each of those tests. I would if I had time, but the bottom line is functional tests, specific tests. You must do a whole battery and then you come out with a provisional diagnosis, definitely. Or you do a battery of tests and come out, that is your screening or your prevention protocol. Caution, I just want to show you one thing about this. We always taught that you must maintain improved hip range of motion. But in the sports world and in terms of hip, because a limited hip range of motion equals hip problems, definitely. But watch this, I wanted to show you. These are all studies, I've got them all written down. There's studies on baseball pitchers, ballet dancers, male versus female, gymnasts, indigenous versus non-indigenous, ethnic differences of male soccer players, tennis players. What's important about all, and those are all studies to show they all have different range of motion. So there are adaptive changes depending on what sport you play. So you can't just say they're going to lie down, drop their legs out, and that makes it right or not right. What is really important that's come out very strongly, Igor Tuck and them came out with it, and the conferences I went to, there's strong evidence that the lower total hip range of motion, so it doesn't matter where you start and end, but your total hip range of motion is a risk factor. So just bear that one in mind. So in summary of tests, you get functional anatomy, functional tests, individualized. You can definitely do screening if you know the risk factors, understand the role that the hip and groin play in movement patterns and dysfunctions. Okay, and rehabilitation, I'm going to go quickly now, otherwise we're going to run out of time. Rehabilitation, there are studies coming through, but this came out very recently saying there's no significant improvement. It's coming now about rehab. But meanwhile, if you know your anatomy, your functional anatomy, you can rehabilitate it. Find your maladaptations. In rehab, functional anatomy, watch, your rehab is based on. Functional assessment, that's what your rehab is based on. Identify all the biomechanical dysfunctions of the entire kinetic chain. Brooklyn Kahn's latest book, he has 9 principles of rehab for hip pain patients. And for the first time, all those 9 principles are about function. And I'm so happy because those are the talks I've been giving now for the last couple of years. If you've got his book, their book, then have a look because it's all about functionality. Okay, so I'm just going to pluck out hip height. Gluteus medius critical, which I said earlier on. It doesn't abduct. It doesn't, the clamshells, those are tensor. You still do them, but that's for the tensor fascia lata. The hip hike is the best. No time to go through it now. Gluteus maximus, very neglected. There's studies for these. Bridging works it, and it also works the hamstrings. and that one below with a dumbbell extension is, the studies show that that works the glute max very, very well. Adductors, because I've said how important it is, this is one of the best exercises according, or you don't have to do it that dramatically, but that works very, very well for the adductors. And by doing the adductor strengthening program, 41% reduction in risk of groin problems. So the adductors are very important. What I've always done is, without even knowing, before I did my PhD, is any exercise, this is a cricketer actually, any exercises they've got, I've always put a ball between their knees like I've got there. So even the rugby players, when they were in the gym doing upper body work, they had to go against the wall and put a ball between their knees. So I made the adductors come into effect for all the functional movements. Monitor the progress ongoing all the time. If they've had a problem, you've got to right through the season, because it's tricky and you might have got the wrong end of the stick. You might pick up something else. So carry on monitoring it, and especially when they're fatigued. So in summary, groin and hip complexities. Is prevention viable? Differential diagnosis is complex. It's not a big deal. If you haven't got the right diagnosis, that's not the criteria. Understand anatomy versus functional anatomy, particularly that particular person plus what a sport they're playing. Look for movement dysfunction patterns and compensatory muscle patterning. So you take time, but it's like a puzzle. It's great. I love it. Offload the pubic joint for sure. Rehabilitation, make the rehabilitation good. Monitor it all the way through the playing, the rehab, monitor through their playing through the whole time. Never let them go straight to surgery. There's a time frame to consider. So knowledge is so important. There's so much. I have learned so much. I wish 10 years ago I'd known what I know now, which is why I give these talks everywhere and want to share, because it's about knowledge. Individualize every person that walks in that door. So these groin quandaries, what is the answer to the puzzle? What is the solution? Prevention, specific rehabilitation, bearing in mind the entire kinetic chain. And you can see at the bottom, I've got latest studies to back me up. So it's not me just saying that. Okay, that's it. Thank you very much. So I'm finished, and I don't think there's time for questions, but if you have, I'm happy to answer them. Hello?
Yes, ma'am. Yes.
Okay, is that it? I'm finished. Do you want any questions asked, or what would you like now?
Yes. Just any questions? Any questions to Dr. Helen Milson?
Well, people can always email me with questions. If you want to send the people who are there, if you want to send them any emails, you're very welcome.
Yes, I have shared your email ID, ma'am, just on the timeline to everybody. Just you can.
Sorry?
I have shared your email.
You can send the participants my email, and if they've got questions, they can email me with questions with pleasure.
Yes. Thank you very much, madam. Well, thank you so much for speaking up in this meeting and providing a unique perspective. Thanks for sharing your tips with us. Looking forward to meet again next time. Yes, this was a presentation from Dr. Helen Milson. So the last speaker of today's session will be Dr. Angelo Seli from McKinney College, from Limark registered massage therapist from USA. The topic will be strength and flexibility factors and their influence on the injury prevention. Yes, madam, go ahead by sharing your slide.
Good afternoon, good morning, wherever you're from. Just let me grab my slides. Bear with me 2 seconds. Okie dokie. So I want to pick up from where the last speaker came off from. Can you see my screen?
Yes.
So obviously, like I was introduced, I'm Angela Sale. I'm a practicing massage therapist and sports rehabilitator from both Canada and the UK. I'd like to talk to you today about the strength and flexibility factors and their actual influence on injury prevention itself. So first of all, what is injury prevention? What is injury? Prevention should be something that is a lifelong habit that anybody that is interested in, I guess, maintaining functionality in terms of their life, whether it's just somebody doing daily tasks, so like a stay-at-home mom, or somebody like that has an elite athlete in their hands. What does injury prevention mean? What does prevention mean itself? So prevention is the stopping or reducing the severity in terms of, in this case, an injury by creating balance or an action to counteract or decrease mental or physical conditions. And we have different things that we can do in order to prevent this. So we have health related things or skill related things that we can do in order to help prevent this from happening, whether it be for our jobs or whether it be for a physical activity. I just want to go down into a bit of a breakdown of what tissue injury is. So the breakdown of tissue becomes injured. What happens? It reaches the elastic or plastic limits. The forces that are applied to it are too great that they cannot withstand the tissue that is being applied to it. And this then causes the fibers to break down. So the stability can be negative, but it also can be a positive thing. When we're looking at preventing things from happening, we want stability. But when it's become injured, we don't want that stability because we're going for a hypertonicity within the muscles. So the muscles themselves are becoming extremely tight and taut, creating more problems in terms of reduced range of motion. The muscles aren't able to do what they want to do, so we get compensatory actions. And that's not good for anybody, whether you are a stay-at-home mom or whether you're an elite athlete. Your body's not being able to do what we would like it to do. Something that is fairly key when it comes to injury prevention is that kind of relationship with that length tension curve. So as that length's applied, the increased muscle to it, the force is also applied to that. And altering this will allow the muscle to change and have a huge impact on that movement relationship patterns. This then, when you're looking at preventing things from happening, can look to see how things have happened beforehand, but how we can prevent them from happening in the future. So how that soft tissue in itself has become injured in the first place. And this is just that length and tension relationship curve in itself. You've got coming up on the left-hand side, the force increasing as the muscle's lengthening. And then we've got that optimal range of motion whereby things are good. And then when we come down on the other side, that decrease, this muscle's still lengthening, but we can't produce any force because the tissue's not been able to withstand whatever force we're putting onto it. Something that I wanted to very briefly look at is that stretch shorten cycle. So when it comes to any stretch shorten cycle, yeah, strength training is imperative, 100%. We wouldn't all be here doing our jobs if we didn't think that was important. And that goes for that concentric eccentric muscle contraction phase, whereby it uses that Golgi tendon organ and the muscle spindle fibers. But things that multidisciplinary teams can actually think about when they're doing this kind of thing is that stretch shorten cycle can actually be used within manual therapy techniques, massage therapy techniques. There are so many different ways that you can get your hands on the muscle to adapt that Golgi tendon organ to influence that muscle spindle fiber to create a stretch shorten cycle. Now, it's not as effective because obviously when we're doing exercises, we want that eccentric phase, we want all that energy, that ATP, to be transferred across to that concentric phase to create that cycle, to create that contraction. Because as we have less time within that transition phase, we have increased muscle production force. So muscle production force will allow us to become stronger, will allow us to be more efficient and effective in the movement pattern, whatever it may be that we're trying to achieve. Simultaneously, this stretch reflex is actually the stretch shorten cycle. So it works in the eccentric phase of the muscles And like I said, it increases the muscle activation. So therefore, we have more muscle activation, we can have a more forceful muscle contraction. So if you take your professional athletes and you're wanting them to do 1 rep max, they can actually produce that force that's going through those muscles at a more efficient manner because they have this stretch shorten cycle going through it. So perfect example in terms of exercise is that plyometric training, whereby your body is exerting power over that short period of time in an explosive manner. And obviously on the screen, I do have quite a few different examples there to show you, but they all use that stretch shorten cycle to their advantage to produce that power that the muscle needs in order to keep it moving. Things that we want to be looking at when we're hoping to prevent things, so the prevalence of the injury in itself. Now, there are certain things in terms of health that, yes, we can change, things like weight, fat body composition, but there are other things that we might not be able to change, like age or height or gender. Anatomical abnormalities are huge, but what we can do is work with them in terms of the skill set to be able to reduce that form from happening. So things like ACL injuries, we all know that they are prevalent in injury prevention. We can skill set those in order to reduce the risk further from any athlete by looking at things like agility, balance, coordination. You look at your normal population, obviously falls within the elderly are huge, but if they had a little bit of balance training, a little bit more coordination training perhaps, then that would be prevented to an extent. And then we look at jobs. So in terms of registered massage therapists, athletic therapists, physios, OTs, chiros, anybody that's in that physical field whereby you're using your hands, you can prevent things from happening. So injuries happen primarily through overuse, obviously through trauma as well, but overuse things in terms of those occupations where you have those hands-on skills are going to be huge. And I will go through that in a bit more detail shortly. You then have your sporting activities. So if you have like contact sports to non-contact sports, yeah, the prevalence of those injuries are going to be different. And then the injury itself in terms of like ACL, shoulder, osteoarthritis, all those kinds of things are going to be more prevalent if you can prevent things from happening in the future. You do have things like time of day or extrinsic and intrinsic factors, environment. Nutrition is huge in terms of you fuel your body correctly, your body's going to give you what it needs. And then unfortunately, women, we have to look at that menstrual cycle. You have more of a prevalence pre-ovulation than post-ovulation. And then, so how can we prevent injury from occurring? In terms of whether it's a trauma, we can't really prevent it. What I guess the slide should say is how can we assist it from not becoming so severe? So maybe career damaging or turning into a disability, that sort of area. And I guess there are 3 key things. Myofascial work, getting your hands actually on that physical tissue itself, stretching and strengthening. So myofascial work works along those myofascial lines, and it decreases that fascial tension. If you can hook into that fascia and allow your body to react to that, so releasing and relaxing a little bit, this can change the way that you move, the way in which when your patient gets onto the massage table or wherever you are, to when you finish with them, they get up and they are massively different. They can move differently than they did pre-treatment. And this is because that fascia connects to the skeletal tissue via the epimysium, endomysium, and perimysium. This creates that network of fascial tissue, which can be defined as multidirectional. Now, anything that's multidirectional, you don't just have to change one direction in order to influence it. This is what makes fascial or myofascial work a massive benefit to anybody, because you can then adjust those biomechanics within the movement patterns, whether it be a correct or incorrect movement pattern itself. When we're then looking at things like myofascial or manual therapy techniques and work, something that is prevalent is those injury markers, those inflammation markers that come in your body naturally as we all have an injury. And when we're looking at doing exercises and going through the kind of work and the protocols that you're going to put in place when you have your clients, that we all do, DOMS is a huge thing. So DOMS is delayed onset of muscle soreness, as we all know. But if we can decrease that incidence of DOMS, we can reduce the amount of inflammatory markers that are in our body. So I guess the question is, how do we do that? And we do that by a few things. We do that by stretching. So that neural adaptation. Your muscles are in a shortened position where we don't want them to be. So stretch them out, create that neural adaptation, stretching them back out to that anatomical position that they should be in naturally. And then strengthening. Strengthening is huge, whether or not you are a stay-at-home mom or an elite athlete, massage therapist, whatever. If you can strengthen your body, you can give it the tools that it needs to physically go forward. And you can have a happy and lifelong career in whatever you're doing. Because what strengthening actually does is it strengthens those cross-bridge formations that happen physiologically within the muscle, which then allows you to have more force acceptance. Okay, so other things are things like joint play. So joint play works by a concave and convex action to the muscle, to the joint itself. So if we talk the hip joint, you've got that concaved in the acetabulum and that convexed in the actual femoral head. And they work together to produce a movement that the body is unable to produce itself. So the muscles can't take it that far. This then influences the soft tissue pliability and that joint structure itself, giving it more range of motion. Massage techniques reduce that tension neurally in that adaptation, which then reduces the sensitivity to pain. Most people will stop doing an activity because they're in pain. So if we can create some form of maintenance plan for people in terms of massage techniques, joint play, strengthening, stretching, whether it be a professional athlete or a stay-at-home mom, anybody, this works kind of universally, then you're going to reduce that pain. You also increase those joint pliabilities and range of motion. So people get more out of life. Now, in terms of things that maybe they can do themselves, stretching, strengthening, obviously, yeah, 100% at home, brilliant, as long as we teach them correctly, but also things like K-taping. They will provide a neuromuscular feedback and they just pull through the dermis. They pull the force through the dermis. This increases the stimulation within those mechanoreceptors themselves. And obviously, all these points I'm putting, they have been backed up by scientific studies on, obviously people work with it because we all work with K-tape, it works brilliantly. And anything that we've kind of discussed in terms of how we can prevent this from happening is a positive way because it can affect that balance and proprioception, which then just contributes to that injury reduction and prevention itself. So a few things I just want to cover is what is strength? Okay, so what is it? Strength is the ability to exert force. Now, obviously within the muscles, we have endurance and strength itself. And that strength is how much force that muscle can be applied to in terms of a 1 rep max. So your muscle cannot lift any more than 120 pounds, yeah, 50 kilograms, dependent on the muscle. That's the strength of it, that it cannot do any more than it's given. Endurance is described as that ability for the muscle to perform a number of lifts or submaximal loads for a lot of reps. And what you're doing then is you're working at a submaximal level. So if the joint or if the muscle can do maybe 50 pounds, then you're looking at maybe working at 30 pounds just to be able to do multiple lifts of whatever the muscle is itself. We all know what goes on within a muscle physiologically. We have that fiber, that muscle fiber, the myofibrils that come to that sarcolemma, which is that cell membrane, really important for getting proteins in and out of the cell itself to give you that muscle contraction. So you've got the actin and the myosin with that sliding filament theory, where the ATP is needed to create those cross-bridge cycles, so that when the muscle shortens, they move closer together, and when it lengthens, they move further apart. We all know that. But what is important, and maybe we're not maybe aware of in the same respects, is how fast that can actually occur. So that force velocity relationship. And we've all seen it when we're in the gym, people try and lift a heavier weight than they should be doing, and the muscle breaks down because the body is unable to take that force on. To understand what force is being applied to that muscle and at what speed. Everybody wants to get through their lives because we're so busy, but your body can't do that. So when we're looking at higher speeds, we want a lighter resistance. So we want a lighter weight so that that concentric phase of a muscle can be achieved and can be achieved without causing any injury. When it comes to higher resistances, they're going to be slower because the body can't have that cross bridge formation to withstand that load applying in the same way as it would do at that higher speed for concentric muscles. So yes, you do slow down, but people don't remember that and try and push forward. I'm sure we've all heard it. I'm sure at some point we've all said it to clients, just push through. You've got this, we can do it. Where sometimes that's good, but sometimes it's bad because it can actually cause micro damage within those muscles themselves because they don't have that cross bridge formation. They don't have that strength. Now, when it comes to looking at eccentric loading, that is obviously working through the power and the speed of that muscle as it's lengthening under gravity. So that will be slower, but we can create a training program in order to reduce that speed and actually increase the amount of efficiency of that muscle itself. So in terms of injury prevention, eccentric muscle contraction strengthening is the way forward. Now, obviously, in terms of the specificity of those exercises, we all know that isometrically the muscle contracts, but there's no change in that length. Concentrically, it changes the length, so it shortens it against gravity or with gravity and resistant forces, and eccentrically, it lengthens it against gravity itself. Something that we may be not considering is the difference between single joint exercises and compound exercises. So single joints obviously train just one muscle or one joint. A compound trains more than one joint. So it becomes a functional movement pattern that your body goes through within a day. So an example of a single joint exercise would be something like a bicep curl. A compound would be like a squat. And how many times do we squat in a day? Well, I'm sure we'll squat to tie our shoelaces. We'll squat to pick up a bag. We'll squat to carry a child. Any of those sorts of things, they're functional. So when it comes to injury prevention, we do want to look at that functionality as well. At the bottom, there's at least a 6% increase in the efficiency when it comes to compound to single joint exercises. And why is it important that we strengthen? So we strengthen to provide stability for that joint against gravity, whether it be going downstairs or pitching a ball. It's providing support through that shock absorption, which then protects the joints because you've got that stronger cross bridge formation. Your body has that higher tolerance to accept that force. And then it provides strength within those basic normal daily movement patterns that we all do. So there's a few exercises there that I'm sure we're all familiar with, but they're all, generally speaking, full compound exercises. They all work the muscles fully to their most functional movements. Something that we're going to go on to now is what happens if your body isn't in the full range of motion. It's not got that full flexibility. So flexibility is the available range of motion at a specific joint. And obviously, if we don't have it, then tissue damage occurs. And that tissue can be anything: tendon, fascia, joint capsule, muscle, because that it gets injured at that flexibility within that specific joint. This not only affects the joint, but the viscosity of that tissue as well, and the tightness within it intramuscularly, leading to that hypertonicity within the muscles, that kind of taut feeling that you get when you get your hands on them. And flexibility is defined both statically and dynamically. So statically, if you have a low length under tension, you're doing a lot. Dynamically, if you can do it with movement, you're actually increasing the length of that muscle, but you're never holding it to that end of range. So it becomes more functional. Obviously, we all know about the physiology, but I just want to kind of highlight a few things. that when those muscle fibers are stretching, there's a decrease in that overlap of the cross bridge formation. We hold it over time. We need more force to be applied, which increases that tension. And that tension can actually be recorded through those specialist muscle fibers. That's then converted into your stretch reflex, so a neural input. And that stretch reflex actually happens quicker than your neurological system, your central nervous system, can process. So your body is actually protecting itself from further damage in the future. Why do we stretch? We stretch to increase joint and flexibility within that muscle. We decrease range of motion, we decrease DOMS, we increase proprioception and the connection between the musculotendinous junction and to reduce that muscle impedance. And we also reduce the rate to which injuries can occur in the future. Examples of stretches there. And again, this just looks at full body. It's not specifically at a set thing. I just want to, before we finish, just look at a few differences with different people or different populations within places. So we're looking at the athlete here. We have things like contact and non-contact that actually decrease by a huge amount. Mommy's just busy, buddy, okay? And we have that sporting activity. So I'm just using NFL players, but you can see the numbers talk for themselves. 56% of people in 2005 had knee injury history. The position on a team is vital to how you would rehab or how you would prevent and do your training for specific people. Professional versus amateurs. Professionals have a wide range of professionals themselves to look for. They have a strength and conditioning coach. They have access to massage therapists, chiros, all these different people that maybe the amateur person wouldn't necessarily have. They just have maybe the knowledge that they find from things like Google. Strength, like I've said, is huge. And in terms of closed kinetic chain to open kinetic chain, that is massive when it comes to looking at the highest scores when being tested for strength. That in itself allows for a correction in those inefficient muscle patterns and balance and proprioception. Okay, so obviously medical professionals, we all really want to be able to do what we're doing for a long period of time. Mommy's busy. I know, thank you very much, okay?
I like your lipstick.
Thank you. Can mommy just finish this?
Yes, yes.
Thank you, buddy. Yeah, so from terms of the medical professionals, maybe look at how many clients you're seeing in a day, that time management between clients, stretch things like your pecs, your forearms, if you're working hands-on, and then strengthen things like your erector spinae group, your glutes, your hamstrings, because 54% of injuries that occur within medical professionals are work-related. Now, yes, okay, we have things like Graston technique and tools that we can use, but nobody's ever said that that's really worth it, okay? And then the last thing I just wanted to talk about is people that already have things going on with them. So they already have a condition themselves. Previous injuries, that is huge. We look at ACL injuries, and if you're not rehabbed effectively, you're going to have maybe Achilles tendonitis. So linking it in and looking at the body as a whole instead of just those specific muscles is going to be more beneficial in the future. Things like osteoarthritis. We want to look at doing reduction for osteoarthritis. It's not fun. So getting preventative things in place is going to be really good. And then on medical conditions, diabetes, connective tissue disorders, neurovascular, they all evolve around being able to be supportive to your body, especially things like connective tissue disorders. So people with this already have the ability to stretch further than they should do. Do we want to stretch them further? No, we want to be able to strengthen it further. We want to be able to give them that support within the movement. But then at the same time, stretching could be effective because it reduces those inflammatory markers. And then things like osteoporosis, right? Osteoporosis is obviously big, but it's because there's no bone density. So let's keep it. Let's keep that efficiency within the bone to be able to support you later on. There's a good saying, if you lose it, if you use it, you lose it. So we don't want to do that, okay? That's all I've got. Are there any questions? This is my son. So do we have any questions?
Any questions? Yes. Thank you very much, madam, for joining this event.
No worries. Thank you very much.
We have enjoyed your speech. Pleased with your topic. Looking forward to meet again next time. Also, have a nice day. If you go to the remaining speakers of the conference, today's conference, only Dr. Sheila Roney from US has left. So we would request Dr. Sheila Roney, you can represent your talk on tomorrow, as we are going to close today's session. Also, if you have any questions or comments, you can text here so that we can ask behalf of the participants. Any further questions? Any questions? Yes. If we go to vote of thanks, thank you very much to all the participants, those who joined this webinar, that is third virtual conference on physiotherapy, physical rehabilitation and sports medicine. That is October, today as well as tomorrow, October 16, 2021. During this period having different time zones. Our sincere thanks to all the keynote speakers, plenary speakers, delegates, journals, collaborators, media partners who have joined from different destinations in the globe for their support and cooperation. Let us thank speakers who have responded so well to our invitation to participate in this conference. We have researched several papers which will form the basis of our discussions in the various sessions. Let us thank you all the associating with this conference by your presence. A special thanks to Program Manager Mr. Kevin Brown as well as Mr. Madhu Bhupati for his continuous effort in putting all together in one platform in this online event. If we go to today's keynote speakers from morning session, that is Dr. Manisha Rathi from India, Dr. Mohammed Takroni from Saudi Arabia, Dr. Sheila Roney from USA has absent. The doctor will be presenting her talk tomorrow. Session speakers, Dr. Hamid Fatalov, Dr. Harej Abdul Rahman, Dr. Akanksha Bajai, Dr. Anna Murray, Dr. Frederick Pisse, Mr. Matthew White, Dr. Edono Sapoji, and Sohail Sohani from Iran. And if everything goes well in 2022, hope we will join in physical event on same topic, that will be virtual conference on physiotherapy either in Dubai or in Europe. Also, I am especially thankful to Dr. Mahmoud A. Takurani from King Faisal Specialist Hospital from Research Center from Saudi Arabia, as well as Dr. Muzweke Tashabola, Physiotherapist Department of Safekyo Makogoto Health Sciences from South Africa, and those who are listening this conference as a delegate like Miss Alumile Ganeshan and Dr. Baranko. I would also thank to participants, all the participants. Hope we can collaborate in future events in physical event. And kindly note, electronic booklet as well as electronic handlet will be sent through email within 3 to 4 working days after the completion of the conference. Finally, we extend our appreciation to each of you for participating in this online conference. Thank you. Once again, this is signing off, Bhupati. Just if you have any questions or comments, you can text here. We'll be closing within 3 to 4 minutes. So within 2 minutes we are going to close this today's session. And one more thing, I request all the participants, those who joined today's session, to join tomorrow as well, because as soon as the speakers completion of their talk, they are leaving. So the other speaker, those who are joining to end of their session, they are giving alone their talk. So it will be a disappointment to all the to other participants. So I request all the speakers or participants, those who joined, to join as tomorrow's sessions at the same time. Please apologize if anything goes well in today's session. Just we are going to close within 1 minute. Any further questions? Yes. ఇప్పుడు ఏం పడుతుంది చూడు ఇప్పుడు. Yes, once again thank you very much to all the participants, those who joined this webinar, Physiotherapy, Physical Rehabilitation, Sports Medicine. That is today's session, the October 15 and as well as tomorrow 2021. Our most sincere thanks to all the keynote speakers, plenary speakers, students, delegates, general collaborators, media partners who have joined from different destinations around the globe for their support and cooperation. Let us thank speakers who have responded so well to our invitation to participate in this conference. We have researched several papers which will form the basis of our discussion in these various sessions. Let us thank all the associating with this by your presence. A special thank to Program Manager Mr. Kevin as well as Mr. Bhupati for his continuous effort in putting us together in one platform. If you go to Delhi, if everything goes well in 2022, hope we will join in physical event on same topic, that will be physiotherapy. We are planning either in Dubai or in Europe. I am especially thankful to Dr. Mohammed Takorini from King Faisal Specialist Hospital and Research Center from Saudi Arabia, as well as Dr. Muzweke Tajubila from South Africa, and a great appreciation to delegates like Alumela Ganeshan as well as Dr. Baranko. I would like to thank all the participants. Hope we can collaborate in the future events in physical ventures. Electronic booklet as well as a handbook will sent through email ID within 3 to 4 working days after the completion of the conference. Finally, we extend our appreciation to each of you for participating in this online conference. Thank you again. This is signing off, Bhupati. Just I'm going to close the program. Just if you have any questions, you can text here. Within 1 minute, I am going to close the program. Thanks once again.